Sir, we are
Yeah.
live.
Okay, sure. So, good evening, everyone. I am Vikas Singh from the medical team of Universal NutriScience, and it's my pleasure to welcome you all to the third session of the ISAR Fertility Catalyst series on behalf of UNS. To start, I would like to reflect on the success of the first two sessions. In an era where webinars have become a commonplace, ISAR Fertility Catalyst stands out due to its unique structure and flawless organization. Each session addresses two important topics and followed by, in the presence of two esteemed speakers and the chairpersons, followed by a unique discussions on the panel discussions as in the presence of moderator and a bunch of IBS experts acting as a panelist. The, the players who have been very essentials in making this ISAR fertility catalyst very instrumental and very positive note is I would like to thank them, the Dr. Amit Patki sir, Vice President Dr. Asha Bakshi ma'am, who have been allowed UNS to do such a wonderful program, and the real catalyst Dr. Anu Agarwal and Dr. Faisal Lewis sir, who have been instrumental in conceptualizing and executing this event. Next few words, I would also like to speak about Universal NutriScience. So we are a nutraceutical focused company and we take pride in offering a high quality products like CoQ-LC, CoQ300, CoQ4, and we are a pioneer in highlighting the importance of coenzyme Q10 in India and by improving the infertility outcomes. And we are first company to bring coenzyme Q10 300 concept in India market 24 years ago. Our sustained presence over the past 2 decades speaks about the volume of the product and the quality. Now, without further delay, I am honored to introduce Dr. Anu Agarwal, who has been the driving force behind the success of the event, along with the second catalyst, Dr. Faisal Lewis. So, Dr. Anu Agarwal is associated with Once Fertility and Test Tube Baby Center and Ayushman Hospital and Trauma Center. She has been the director of all this Ayushman Multi Speciality Hospital. And again, moving to Dr. Faisal Lewis, sir, who has been the professor and HOD of Department of Reproductive Medicine and Surgery from Amrita Institute, that is AIMS Institute of Medical Sciences and Coaching, Kerala. Over to you, Dr. Anu ma'am or Dr. Anu sir, and we can start introducing Dr. Amit Patki and then we can take from there.
Thank you. Thank you, Mr. Vikas. A very good evening to all of you. It is really my pleasure to welcome you all on behalf of ISAR to this third episode of ISAR Fertility Catalyst series, exploring newer horizons in ART. And obviously, we all should be well knowledgeable about this, like what new is going on in ART field. So first of all, I would like to invite our President ISAR, Dr. Amit Patki, to give us blessings. Sir have been instrumental to start this series, and without your support, sir, it would not have been possible to start. Welcome, sir.
A very good evening to you all. And at the onset, I must thank the national conveners for this webinar, Dr. Anu Agarwal and Dr. Faisal Lewis, who very readily took up this opportunity and hard work to get this series rolling. I must also thank UNS for very wholeheartedly coming to support this educational endeavor. Fertility Catalyst is unique because it dwells into controversial stroke trending subjects in our specialty. And today I cannot be more true than two hot topics that are going to be discussed. One is non-invasive PGT, and we have an excellent speaker in Dr. Kanti Bansal. And the next equally hot is AI for sperm selection, and we have our very charming and informative Dr. Ashwini Kale. We also have an exciting panel which is going to be led by Dr. Monica Singh, a very, very astute, a very scientific ISAR executive members. And I'm thankful for all the panelists, Dr. Aditi Gupta, Dr. Mitali Gupta, Dr. Purnima Tiwari, Dr. Nurada Pancholi, and Dr. Soumya Mathur, and Dr. Saili Kandari. So I think we are all eagerly waiting to listen to these people. And I'm glad that Dr. Rishikesh Pai has consented to be the chief guest and Dr. Charudat Joshi as the guest of honor. I cannot thank my two big supports, Dr. Asha Bakshi as secretary and Dr. Charu as chair of embryology in all my endeavors. They have wholeheartedly supported, and I'm so glad that ISAR has conducted not only very fantastic but successful regional conferences and one national embryology conference. I invite all of you all at the end of this month for the National Yuva Conference to be held in Patna. And I'm sure that is also going to be a great success. And we end the year with a fantabulous conference, which Dr. Rajul Tyagi has conceptualized in Lucknow. And I hope we all can be there in large numbers to support them. So thank you once again. And I thank Dr. Anu and Dr. Fesi for this excellent webinar, Fertility Catalyst. Thank you.
Thank you. Thanks a lot, sir. Now I would like to invite a vibrant secretary, ISAR, Dr. Asha Bakshi, ma'am. Asha Bakshi, ma'am, you have been so charming and so helpful. Whenever I called you up for any help, you always pick my phone. Thank you, ma'am. Welcome, madam.
Thank you, Anu. And first of all, I must congratulate you and Dr. Fesi Louise for such a good program, because we need these programs so that all the time our brain keeps on working and thinking what next, what should we do to level up our practice, because day by day we want to increase the level of our practice, and it's very important to have programs like this. And under the leadership of Dr. Amit Patki, ISAR is really doing a great job, and lots of academic activities are being done, and I'm very proud of being with him in his team. Then I would like to greet and welcome Dr. Rishikesh Pai and the chief guest today, and Dr. Charudat Joshi. And Dr. Rishikesh Pai, we all know that he is all the time bubbling with knowledge, and all the time he gives us practical tips, which are so good. Whenever I listen to his talk, I always come and start some changes, make some changes in my practice. So, and Charudat Joshi again is very helpful and very updated. And at the same time, PGT, we talk a lot about PGT, but which PGT should we do? Should we do the invasive PGT, or should we do the non-invasive PGT? And what is the, to say specificity and sensitivity of non-invasive PGT? We all want to know. So I'm sure Dr. Kanti Bansal, who is very updated and has been in US for a long time, will tell us about all the points that whether we should really be doing it or not, or is it just a thing to be talked about. Then again, people are talking a lot about use of artificial intelligence. So how practical it is, that will be told to us by Dr. Ashwini Kale, and Monica is going to talk about neuroovulation protocols, which is very, very important for us clinicians, because we come across various types of patients, diminished ovarian reserve. All of a sudden you find that unexpected poor response is there, or a a resistant PCO cases. So I'm sure Monica and her panelists, Dr. Sayali Kandari, Dr. Akriti Gupta, Dr. Mitali Gupta, Dr. Pramila Tiwari, Dr. Purnima Tiwari, Dr. Soumya, and Dr. Anuradha Pancholi are really going to discuss and bring out some good points out of this panel discussion. And I would also like to welcome Dr. Rajul Tyagi, Dr. Srinivasan, Dr. Randhir Singh, Dr. Neelam Ori, Dr. Priyankur Roy, and Dr. Nishat Chimote for being the chairperson. So I think I should really finish off here so that you can carry on with your program. So best wishes again, and happy learning to all of us.
Thank you. Thank you, madam. Dr. Fesi?
Yes, I think it's a proud privilege to be part of this ISAR Catalyst series. I think we are waiting for Rishikesh Bhai, sir. Sir told sir will be joining.
Yeah, I'm here.
Okay, sir. Okay,
Good
sir.
evening, sir.
Good evening,
Hello.
sir. Welcome to ISAR Catalyst series.
Huh.
I think we are really honored for you to be here part of this ISAR Catalyst series. So actually, you doesn't need any introduction for any of infertility specialists in India, but as a formality, I like to introduce you, sir, Professor
No
Rishikesh
need
Pai.
to go deeper, Pesi. Yeah?
Yes, sir. Yes, sir. Is the president of FOXY, Federation of Obstetrics and Gynecology. Is a professor of reproductive medicine at DY Patel, Mumbai. And Sir was the president of ISAR and also the regional trustee of Asia Oceania of the FIGO, World Organization of the Gynecologists, and also the liaison officer of the FIGO Women's Cancer Committee. And he's the medical director of Bloom IVF and 11 IVF centers spread across India. He is steering committee member of WHO Global Summit on PPH and subcommittee co-lead of Innovation of the Equity Forum voted by the Bill and Melinda Gates Foundation and National Institute of Health, USA. He is also the past president of IAGE, and also he is the past president of IVF Society of India, as you know, ISAR, and also for the International Federation of Fertility Specialists, that is IFFS, board of director for past 9 years. Academically, he has contributed a lot by winning the 62 awards, including a FRCOG fellowship by the Royal College, and also delivered number of orations, more than 40 orations, and 700 lectures, and edited a lot of books. And when we were starting the doing postgraduate and starting gynec practice, the SARS books were our motivation to take in infertility. And also to last, he will be the scientific chair of the All India Conference, that is ASCOG, to be held in Mumbai in January 2025. Over to you, sir.
Thank you, Pesi. I would like to thank you and Anu Agarwal who are convening this program, and I would like to pay my respect to Amit Patki. I think he's not there, but Asha
Yes.
Bakshi, who is our
Amit Patki sir is here.
Amit Patki sir is here.
I'm
Acha.
there, and Rishikesh, my best wishes for your
Okay.
FIGO endeavor.
Yeah. Thank you. So both of them are my good friends, and hopefully Asha one day will also become president of ISAR. So anyway, and Charu is our chairman of embryology, and all of you are there. I mean, I don't have to take your names. All of you are there in full force. Basically, I'm just under a lot of pressure at present. The biggest pressure is the All India Conference, which is just round the corner, and I have to see that all of our ISAR is represented, and I'm going to give this whole thing to Dr. Amit Patki and Rohan and Asha to do. So there are 2 halls in the ASCOG which we have earmarked for infertility for the 3 days. That is Friday, Saturday, and Sunday. So all of you hopefully will be, all the important people will be factored in those 3 halls. And nowadays everyone wants to talk. So some of you will, of course, have to be panelists, and some of you will have to be chairs. So we look forward to that. And then, of course, we are looking very eagerly forward to our annual ISAR. Rajul Tag is there, and in our Lucknow, so the only 2, according to me, let's put it that the 4 main branded conferences now every year are the AICOG, the ISAR annual. To certain extent, I would not say it can't equal ISAR, but IFS annual and the ACE annual. So these are quite branded now, and the IAG annual. So I think is ISOPAP annual also to certain extent. Many of the obstetric people, they go for the ISOPAP NARCHI, and of course the AICC RCOG is also a good branded conference. So some of the important conferences are now branded and more or less have got established in the national scene kind of in. And we all look forward to these conferences. Of course, the other conferences are also there, and there are not many conferences, but I'm sure that we all enjoy. So it's not just the knowledge, but the fellowship also, which is very important. And I can see a lot of, as far as fellowship is concerned, a lot of important people like Neela Mori is there, and Dr. Randhir, Monica, and Kanti, of course, our speaker, and Chimote and Srinivas, I can see. And so a lot of people are there on this thing screen. Non-invasive PGT was actually first started by me in India. Me and our group started it. And mainly I feel that, so what I've done is that I feel that there are two types of indications for PGT. One is the recurrent miscarriage, and the second is the recurrent IVF failure. So I feel for the recurrent miscarriage is quite a traumatic experience. So you need to be very accurate, and there you should do the invasive PGT. So biopsy would be a better deal for recurrent miscarriages. While when there is a repeated IVF failure, a non-invasive is very good to do, because it's not that accurate, but it gives us just a general idea as to which embryo to put inside. In between, I had started the artificial intelligence live whisperer, had come from Australia, which was quite good because it was not invasive, but unfortunately, it is going under. Means it is shutting down. So that's a big setback for us. So because it was a wonderful system, but I think financially the problem now in our world is that the supply has become more than the demand. So this is creating stress in financial circles, including in hospital circles. So there is a lot of future. Many hospitals will shut down because of debt, because the economy of the country has not expanded. So, and so one of the things I would like to say to all of you is that we must hold the bottom. It's very important to hold the bottom. If we open the bottom now, we will all be finished, and with us the patient will also get finished. So if we have to give good care to the patient, the bottom, this that the lower, you can't just go on discounting and killing each other. So there has to be a lower bottom. And I always believe that if the patient is not well off, no, if it is 1.3 billion population, you just do it free of charge for them. You don't have to bother with it. But in the remaining 100 million people who are there in, or 200 million people who can afford, you need to, as a collective, you need to have a hold the bottom at some level. We are the cheapest country in the world. I used to do IVF in Kenya. There also they are charging 3.5 lakh rupees. Here we are charging 50,000, 60,000, 70,000. So where is the bottom? No? So you have to, otherwise we'll kill each other. And if all our units start killing each other and losing money, then our patients will suffer. They will not get the good care that is there. So it's very important to, of course, academics is important, but this is also important. Commercial aspects and viability of units is also an important part of future of IVF movement in the country. So I would like to end myself here, and I would like to wish you the very best for a wonderful interactive session. Thank you.
Thank you, Rishikesh, and all the best for your, FIGO contest. Yeah.
Thank you.
Every time you give some good point.
Before I sign out, let me tell you this, that if I go for the FIGO post now officially, it is important to understand that it is not me who is standing. If I get elected, I'll be one of the first, technical IVF person or to become FIGO. There was another Egyptian, Sama Gerur, who is Amit Patki's very good friend, Gamal Serur. Amit, he was also IVF guy, who was the FIGO president.
He is the president of the Egyptian Fertility.
Right. So Egyptian Society. So I'm saying that we all have to. So I'm an IVF person. My family is IVF. You are my family. Okay. So when I fight the election, I'm fighting it with you. If I win the election, I'll take all of you there in the center. So it's our election next year. It is our family's election. So, and I've also been the family part of the endoscopic family. So this is together we fight the election as a part of a group. Okay, I'm not doing it for myself. I'm just representing our country. So that has to be clear. So together we'll fight. So the Cape Town conference is from the 5th to the 9th of October in Cape Town next year. So that's where we must be in full force. And India will, how it is, ultimately take over the world as well. So thank you very much. I'll not bore you much for this, and wish you the best.
Congratulations, sir. And we all will go in large number to Cape Town next year.
Thank you.
Yeah, absolutely right. We will.
All the best, Dr. Pai. All the best.
Present India. We are proud of him.
Thank you. Thank you.
Definitely,
I will be there.
Thank you.
Okay, thank you, sir. Thank you, sir, for coming.
Thank you.
And giving us.
Thank you, sir.
I think next we have Dr. Charidatta Joshi. He is the from Belgium, and now doctorate also doctorate in life.
laptop.
Hello. Okay. Trained in ART and allied procedures from Belgium, Singapore, and Germany. Served as office bearers of various societies like ISAR, IFS, ACE, ISSRF, ISPAR. Past vice chairperson of ACE Academy of Clinical Embryologists, and past president of ACE from 2014 to 16. So medical director and Gene India ART Bank Indore. Lab director of RD Guard Medical College Ujjain, and chairperson of embryology now, that is from present. So we are honored to have you, sir, for our ISAR Catalyst series. Over to you, sir. Hello.
Thank you. Thank you, Dr. Lewis, for introduction. I will not take much time, and I just like to congratulate Dr. Lewis and Dr. Anu Madam to organize such fantastic series. And yes, I always feel that there is a scope of this latest technology to be involved in this ART field. And because ultimately patient wants result, and when everything fails, they ask what next. So artificial intelligence and non-invasive PGD are the techniques which we are coming across. And I hope that these are going to be the really helpful tool in getting success rate higher. And to just give an example, recently we had a conference in Pune, ACE conference, where I saw remote ICSI. Means you can, sitting at your home, you can perform.
Hello.
So I think there is not taking much time. ISAR is always there to promote such activities, and particularly in field of embryology. So we are very thankful to ISAR, Dr. Patki, Dr. Bakshi Madam, and just hand it over back to you to start the session. Thank you very much.
Thank you. Thank you, sir. Now to start our scientific session, our first talk is by Dr. Kanti Bansal, Non-Invasive PGT, Fiction or Fact. I would like to invite our esteemed chairpersons, Dr. Rajul Tyagi.
Hi, everyone. Hello.
Hi, ma'am. Ma'am, please display a CV of Dr. Rajul Tyagi.
Yes.
Ma'am, we all love you. Ma'am is Vice President ISPAT Managing Committee. She has Vice President ISPAT UP Chapter, Secretary IHFRF, and Madam is organizing chairperson of, Madam has been, organizing chairperson of ISPAT 2022, organizing chairperson of ISAR UP Chapter. And she has taken various international infertility training and so many awards to her. Madam, she has won Nari Award 2014, Sri Shakti Puraskar Award 2015, Aspiring Gynecologist and IVF Specialist of India Award 2019, ISAR Champion Award, Corona Warrior Award, Aspiring Gynecologist of UP by Deputy Chief Minister UP. Welcome, ma'am.
Hi, everyone.
Hello, ma'am.
Yeah.
Next.
Thank you. Thank you, Dr. Anu and Dr. Fesi, for inviting me on this platform. And this fertility expert catalyst is really a unique series of webinar which is going to be enlighten us with the latest update in field of infertility. And today's speaker, she's a well-renowned speaker, very learned, Dr. Kanti Bansal, and she's taking lecture. She's going to speak on about PGT, which is really in need of the hour. And as nowadays, so many nowadays patients are going for fertility treatment in the advanced age, and in advanced age, doing PGT is really worth, especially in the elderly patient and in cases of recurrent implantation failure and recurrent abortions. So this is the very burning topic, and each infertility, each of us whosoever is doing infertility should be very much aware of PGT technique. So I will like to hand over the mic to Dr. Kanti Bansal.
Rajul ma'am, just let me invite our two chairpersons also.
Okay.
MS Srinivas, sir. Sir
Hello.
is director. Hello, sir.
Hello.
Sir is director and chief embryologist at Care Fertility. He is director and principal embryologist,
Dal chawal?
Private Limited. He has
नहीं,
done
dal
fellowship
chawal
in
dal.
clinical embryology. He is founder president Academy of Clinical Embryologists, ACE India. Sir is chairperson ISAR Embryology. Welcome, sir.
Thank you very much, Dr. Anu Agarwal and Louis, conducting this particular, catalyst fertility ISAR, which is very important to catalyze each and everybody who is practicing infertility with a new advanced technology. Today, Dr. Kanti Bansal and Dr. Ashwini Kale, they are going to speak about the technique which is very needed for selected patient, actually, that is a non-invasive. See, invasive is the one actually where you have to spend so much money. Now it has come non-invasive. With this only you will be able to cut down the cost and you will be able to give the service needy couple. Again, coming to Ashish Kale's talk actually, which is on about artificial intelligence. This is a new trend actually. Wherever you go, artificial intelligence comes into the picture actually. Definitely in future it is going to be useful for not only for infertility, in the entire health sector. With this, I'll finish my talk. I will wish you all the best for this particular program. Thank you very much for inviting me.
Thank you, sir. Our next chairperson is Dr. Randhir Singh.
Hello. Yes. Good evening, everyone.
Good evening, sir.
Good evening, Randhir.
Can you
Where's
show
Randhir CV?
TV?
Anyways, we all know him.
Yeah, there is no need. No need. Anu, just put up the CV of our speaker. I'll introduce her.
Yeah, please.
You just introduced that he is husband of Monica Singh.
So without CV, I can tell that Kanti Bansal ma'am is one of the senior most person who started the IVF in Gujarat. And she has been I think, not only limited to the Gujarat. I have seen her in many satellite centers. Whenever I go to Lucknow, I used to see her. Whenever I used to go many cities. So I think without wasting much time, and we are very, very lucky that you have come back again with a gap of few months to our India. So welcome back to Ma'am India, and we want your experiences in this form of webinars. That is important. Next, we'll go for the topic. Yeah, there's no need for my slide. Then about the what I'll take that earlier my co-chairpersons, Rajul ma'am and Srinivas has told. My take-home message, being a legal lawyer and all, the proper indication, because in the ART Act 21, they have not clearly defined the indication proper for PGTs. So I think, ma'am, after your 1 hour topic of our topic, we should conclude something that what useful indications are that. So, ma'am, the platform is with you for all. Continue.
Madam, you can share the slides.
Yeah. So good evening, everybody.
Visible. Yeah.
Am I audible?
Yeah.
You're audible, ma'am. Audible.
Okay. Good evening, everybody. Thanks to Dr. Amit Patki, Dr. Asha, my very good friend Anu, Randhir. I hope I'm not forgetting anybody. All of you for having invited me here. for having this very, very interesting talk on non-invasive pre-implantation genetic testing. I think it's the topic of the day because just because it is non-invasive, it has really struck my heart, and I want that it to be really a fact very soon, so that all of us will be able to use it. So ART has come a very long way from the first IVF baby that was born way back in 70s. But though we feel all these embryos are so good, very nice, and morphologically they are good looking and very well prepared endometrium, but then there is a genetic factor that prevents the transferred embryo from implantation, thereby causing implantation failure. Now, in women of advanced maternal age or with high DNA fragmentation, what we call it as a DFI, or any previous family history of a genetic condition, embryo biopsy for pre-implantation genetic testing plays a pivotal role in helping doctors and patients to make more informed decision on the embryo that should be transferred. That means we can pick up the best euploid embryo for implantation so that our clinical pregnancy rates increase. Now, we have all these, in the pre-implantation genetic testing, it comprises of PGTA. What is PGTA? It is aneuploidy, and PGT is pre-implantation genetic testing. M is monogenetic disorder. You will come across all these later on in my lecture, like PGTA, PGTM, PGTSR means structural rearrangements. NIPGT is what we are interested, that is a non-invasive. Now, despite significant advances in ART from 1977 onwards, the success rates are very low, and it's less than 30%, leading to live birth. Here, I want to tell you all that it's 30% is live birth. It is not, I'm not talking about the implantation rates, etc., pregnancy rate, is the live birth. Otherwise, we can have even 60-70%. So how to increase this live birth? That is where we want the non-invasive pre-implantation genetic testing to be. Now, you can see in this beautiful slide, the graphs, where we have trisomy 21 and trisomy 18, they have upward rise in the graph where they're touching about 8 and 0.12%, whereas the monosomy X is the monosomy X is just a flat. It is not that much high like trisomy 21. It's just a flat graph. It is around 0.1 only. Now, indications for genetic testing currently. We have to, what are the indications? So we have to define the genetic causes of infertility. We also have to identify couples at risk of transmitting a genetic disease to their offspring via carrier screening. That's what even Dr. Rishikesh Pai just now told in his talk. And then reduce the chance of an affected pregnancy for high-risk couples via ERT combined with PGT, that is pre-implantation genetic testing, for, I told you, PGTM or for structural rearrangements. Now, continuing with the indications, reduce the chance of an affected child via prenatal diagnosis, but also we need to improve ART success. That means increase implantation and live birth rates and reduce miscarriage rate. The latter is approached through screening embryos created by ART for chromosomal abnormalities, an approach known as PGT for aneuploidies, PGTA, with the aim to detect and transfer embryo to the womb. Now, PGT is performed on what is it performed? So, invasive technique for PGT testing is performed on polar body biopsy, cleavage stage biopsy, blastocyst stage biopsy. Now, this blastocyst stage biopsy has become the most common method that is being used these days. Now, in this method, pre-implantation genetic testing is performed on approximately 5 to 10 cells derived from the trophoectoderm layer that gives rise to the placenta and does not require a biopsy of the inner cell mass, which ultimately gives rise to the fetus. Now, the polar body biopsy, I am not going into the details of all these invasive techniques. I've written everything for my own satisfaction, but I'll just tell you all the names of all these because my main topic is the non-invasive PGT. So we also have this polar body biopsy, and if somebody wants all the details, I can send it to you all. Now we have the cleavage stage biopsy, wherein you see how we hold the whole blastocyst and remove the cell and do the, from the blastomere. And then we also have a trophoectoderm biopsy. Here also we hold it with the holding pipette, take with the biopsy pipette, and then ultimately a biopsy fragment of the trophoectoderm is done and sent for examination. We also have blastocyst fluid. This is a minimally invasive procedure where with the help of a XC needle, we remove the fluid, and this fluid includes embryonic cells and DNA. So this is also, we can detect any chromosomal abnormalities by this fluid. Then pre-implantation genetic testing for aneuploidy is also there. Now, for monogenic disorders, I'm not going into the details because these all come under real pre-implantation genetic diagnosis, invasive. Now is my topic starts non-invasive pre-implantation genetic testing. So in this field of ART, non-invasive techniques for evaluating embryos are now becoming very more and more interest is there and more significant. So from changing the sperm preparation technique to biopsy techniques, the role of non-invasive technology has aspired many people nowadays. One of the main advantages is that less invasive biopsy stress is applied to the embryos due to loss of embryo manipulation. Minimal intervention may be advantageous for the fetus growth and well-being. So the TE biopsy procedure requires appropriate handling as well as appropriate training. So we need appropriate people to do that. Now, blastocyst fluid aspiration. A typical human embryo develops into fully developed blastocyst after about 144 hours after fertilization. And the cavity is known as blastocyst, which has a capacity of 4 to 6 N, begins to form on day 4 and fully develops between days 5 and 6. So the genetic material is amplified to a great degree of variety as suggested by the variations in amplification rates. Significant differences in the outcomes between PGT-A and blastocyst are also observed. Now, a related concern that emerges and can be addressed is related to the various variations in the genetic coherence between trophoectoderm and blastocyst cells. Embryonic proteins are discharged into the blastocyst where they may accumulate. So this is the blastocyst, aspiration. So this was first conducted by Watson and colleagues, and they said that there's a regulation over the movement of the molecules into and out of the enclosed blastocyst fluid. So the surrounding monolayer of this TE cell form a solid barrier separating the blastocyst from the external environment through tight connections. Due to the absence of impurities from the culture medium, the blastocyst can offer an extremely pure sample of embryo secretion. See, this purity is very important to get the right, decisions or testing, proper result of the testings. To acquire blastocyst samples from viable embryos, a micromanipulation technique known as blastocynthesis was developed. Embryonic DNA was collected using this methodology for pre-implantation genetic screening before invasive biopsy techniques were developed. So this is also again before the non-invasive techniques were developed. Now we come to spent embryo culture medium, that is SECL. So the wide range of substances that embryos leak into the medium known as the secretome have been the subject of multiple studies over the last 10 years. Here, the SEM of the embryo presents a viable substitute for the non-invasive genetic evaluation of pre-implantation embryos. Examining genetic information, it appears that the SEM occasionally contain more DNA than the blastocyst fluid. So there have been reports that discovery of the mitochondrial DNA and genomic DNA SEM as early as 2 to 3 days of development. It is so early, the DNA is seen. So the amount of DNA has been seen to rise during embryo culture, indicating that a significant portion of the genetic material found in SCM has an embryonic origin, even though various media formulation may contain DNA contaminants, which is a reason for concern when thinking about genetic testing. So everywhere we find some problem in the testing because it's still very new, this NIPGT. Now, let us, think where are we as far as non-invasive PGT is concerned. So the discovery of DNA in blastocyst fluid and spent culture medium from the embryos led to the development of non-invasive PGT. So we have understood till now that it is from this. So now NPGT can avoid embryo biopsy damage. It's such a great thing. If we are able to find out some, genetic problem, but then the embryo is damaged, and what is the big deal in doing such tests? So by doing NIPGT, we decrease the patient cost and require less micro manipulation, and we can give them more euplite embryos to be transferred. So conventional IVF seems to be the most appropriate insemination method in non-male factor infertility. So here we have compared how we used to always think it's so good, conventional IVF. And till today, I think that all patients should not be done ICSI, and there is a room for conventional IVF where the sperm selection is the best as far as nature is concerned. Now, ICSI has been recommended for cases requiring PGT of embryos according to the American ASRM, ISRE, and PGDIS, and also fertility study in 2020. The rationale for ICSI use is to ensure monospermic fertilization and eliminate the possibility of contamination from sperm. So this problem is there in when we are thinking of the conventional IVF, where sometimes there may be more than one sperm causing problems. And because now sorry to say, but embryologists are not looking for the pronuclea, and then we may miss, and there may be pregnancy losses as well. So for the same reason, NIPGT is confined mainly to embryos derived from ICSI fertilization, which decreases the accessibility for a wider selection. Continuing with where we are with NIPGT, though the cell-free DNA is collected from the spent culture medium and sequenced on next generation sequencing platform or analyzed by array comparative genomic hybridization following whole genome amplification as the mainstream pipeline. Actually, this topic which is given to me has both the clinical side as well as the embryologist side. I think more pertaining to the embryologist side. So the clinicians may feel it a little difficult to follow, but then I think I'll be doing justice only if I talk about everything. So however, the genesis of this cell-free DNA remains a question. Genomic and mitochondrial DNA contents were identified by the SCM. For the genomic DNA, both blastocyst cell types, trochoectoderm, and inner cell mass are major sources. The cellular mechanisms driving the DNA release into culture media, apoptosis and necrosis. So for some insightful genetic diagnosis through NIPGT, the laboratory SOPs, protocols, as well as culture conditions and medium to be adopted, and skilled person needed to improve the solidity of NIPGT. It is very crucial that we avoid the maternal DNA contamination from culture media. So proper denudation, media changes, and serial washes of embryo before transfer to the culture drop are mandatory. Otherwise, we are not going to get the proper result. So embryos also should be handled individually to avoid cross-contamination. Another concern about NIPGT is the extended embryo culture to day 6 or day 7. It cannot be done on day 5 embryo. That is a very big concern because only day 6 will give us the proper result. So this is one more, which is it has taken a backseat, NIPGT. The reason behind this elongated culture system is to increase the embryonic cell-free DNA quantity, consequently making a significant difference in concordance between TE biopsy, ICM, and whole blastocyst. why we need the day 6 or day 7? Because as we, the embryologists, again, I'm saying they will know better, because as we grow these embryos to a higher day, then we are changing the, the media, we are putting into newer dish. And so all the embryonic cfDNA, that is cell-free DNA, will be more in quantity. Now, this is a very schematic representation where you can see culture medium collection on day 3 embryo development and culture medium collection on day 6 of embryo development on the right side. And now you can see how it goes on from 0 to 4 and 6. And, the spent culture medium on day 3 and day 6 to identify biomarkers. And then in the last, in the box, you can see the NIPGTA protocol, wherein from day 0, it grows up to day 6, wherein the fluid is taken from the day 6 embryo, and it is tested for the chromosomes, etc. Now, non-invasive tools beyond PGT, biochemistry. So, to isolate a biomarker for embryo culture from day 3 cleavage stage to day 6 expanded or hatched blastocyst, the researchers include quantity of the amino acids released by the embryos in the SCM. So even with biochemistry, we can do the NIPGT, and also presence of serine and histidine in day 3 culture medium as potential pregnancy marker of embryo. Now, going again towards the biochemistry of NIPGT, proteins such as HLA-G, which plays an important role in immune tolerance power in pregnancy, level of IL-6 in SCM, metabolic stress in embryos, as increased levels of lactate in embryo culture media that do not reach to blastocyst stage. So stress in the embryos is very important, and we should try to decrease as much as possible oxidative status of the embryo SCM through thermochemiluminescence as a direct biomarker for embryo implantation potential. Now, what are the other factors influencing non-invasive PGT? The information through NIPGT can be influenced by several factors. Mainly, these are the ones. The culture day medium when cells are collected. I told you already, day 6 is important. Maternal contamination by cumulus cells or any external factor. Any micro manipulation of embryos or previous changes. And also, it is an eye-opener here that even the ovarian stimulation protocols that we decide, that also can influence the NIPGT. Now, there are some advancements in the NIPGT. Currently, this technique is widely used for NIPGTs or NIPGT-A. Okay, the challenge for NIPGT technique is extended not only for genetic assessment for copy number, but also for embryonic analysis for segmentation or rearrangement for monogenic conditions or diagnosing mosaicism. So it is not only a NIPHT, but also for embryonic analysis, which is really very important for diagnosing mosaicism. So culture time to optimize embryo cell-free DNA analysis for frozen thawed blastocysts undergoing non-invasive pre-implantation genetic testing for aneuploidy. So again, the spent media and the whole blastocysts were then collected for further analysis. Spent media and the whole blastocysts were amplified using the whole genome amplification and sequenced using next generation sequencing. So this one, you all can see it is as new as September 2024. This has come in the fertility sterility volume. And here, just the explanation of what I just talked, day 5 frozen, that is day 5 short. And these blastocysts were cultured for 8 hours. Then we have the day 5 frozen. These blastocysts were cultured for 24 hours. So this is known as day 5 long. And day 6 frozen thawed. That means these blastocysts were cultured for 8 hours. So that is known as day 6 short. So we have day 5 short, day 5 long, and day 6 short. So they, just saw in all these which had given better results. So result of the study, Regarding blastocyst expansion grade, informative rates were lower in day 5 short compared with day 5 long and day 6 short, regardless of expansion degree. So we need to go to that level. This decrease was significant for Gardner grade expansion, grade 3, 4, and 5, 6. In addition, for a similar time in culture, the grade of expansion did not have an impact on the informativity rates. For concordance rates, no significant differences were observed among 3 groups. In all cases, concordance rates were 90.5% for day 5 short, 93.6 for day 5 long, and 92 for day 6 short. No impact of the expansion grade was observed on concordance rates. So, non-invasive PGTA in frozen thawed blastocysts yields very high concordance rates with whole blastocysts, possibly limiting the need for the invasive PGTA and making it available for a wider range of patients. So it is useful in the PGTA cases. Now again, this is a very schematic representation of mechanisms for the release of cell-free DNA and SECM. EVs are reported to carry protein. That means extracellular vesicles, they are reported to carry protein, messenger RNA, miRNA, mitochondrial DNA, as well as genomic DNA. And even the elimination of anucleate cells, what they do, they have a autophagy. They die on their own, and also apoptosis. And because of that, the secondary necrosis, which again will give rise to cell-free DNA in spent culture medium, which may hamper the results. Now, coming to the last part of my talk, we have to discuss the ethical issues. We all know what happened with the Monash IVF. It's a very big. When we started in 1996, when we started, that time Monash was doing very well IVF. So fertility giant we call Monash, and they settled the class action with more than 700 patients over inaccurate embryo screening testing. So the lawsuit clearly shows the test has major limitation and is not yet ready for clinical implementation in its current form. They had to give a lot of money to the court for settlement with the court for giving wrong results, and that is so because of that, it's an eye-opener that we cannot just go and do something which is not really a fact. So now the evidence, studies that use the whole embryo as the analyte showed agreement rates with NIPGT ranging from 56
Madam, sorry
to
to
96.
interrupt.
Yeah.
Ma'am, we are getting slightly late.
That's it, only 2 more. Okay, 2 more. So here you can see the rates are from 56 to 96%, and it is completely sensitive to DNA contamination. So again, we have to find some solution. And all the societies are saying no for using this. And key questions for this use: how many euploid and aneuploid embryos? And so many questions are here that we have to answer. Who pays for the negative control NGS test? What is concordance rates, etc. So this and I would really like to conclude saying that we have to still do a lot of research as far as this non-invasive PGT is concerned. It's a very not a very easy thing to do, but definitely we can do with a lot of hard work and efforts. And so take home message: embryonic cells release DNA in the spent culture medium, and the concordance rate of embryos vary between 60 to 90%. Need a consensus. D6 media high quality blastocysts only yield results. Protocol has to be properly done, and laboratory guidelines also need to be established in India. So, dear friends, NIPGT fact or fiction? Not a fiction for sure, because all that I told you was all about NIPGT, which is going on and on and on. And after validation, we surely need validation before we turn this NIPGT into a fact. Yeah, I cannot say whether things will get better if change. What I can say is they must change if they are to get better. So thank you, dear friends, for a very patient hearing. Yeah.
Thank you, ma'am, for a wonderful and crisp talk.
Yeah. Thank you, Kanti. Ma'am, you have spoken so well, and I think I noted that limitation was only that it cannot be done till day 5 last. You need to say day 6. My other chairpersons will highlight on that. I request Rajul ma'am and Srinivas sir to speak.
Rajul madam, are you there? Srinivas, are you there?
I think they left.
So I think Faisi and Dr. Anu, and you will be. This is very good, innovative topic, because nowadays we are getting lot of elderly married women for IVF, and this will be very good. And as I requested before your talk that the ISMR has not. I'll not say ISMR. The ART Act has not defined the indication for PGT, whether it's non-invasive or invasive. So that they have written, what is that? Is that if you have only any genetic disorder, on just high maternal age is not an indication now. So it is the any genetic history, either by pediatrician or by genetic disorder. So I think it need little way, and I think because it was in last ACE conference, Dr. Srinivas was there. It was a panel discussion for indications for PGT. So that concluded that ultimately it has to be given to the national ART, and we have to include a high maternal age is one of the tools. I think, Kanti ma'am, you must agree here.
Dr. Randir, one thing I wanted to stress here: once NIPGT comes in vogue, once as Anu wants it becomes a fact, then half of our headache will be over, because without any invasion, we'll be able to put euploid embryos. Without any problem, we will get healthy babies. Without any problem, we won't have any implantation failure, recurrent pregnancy loss, everything is gone. Actually, the obstetrics people will become, without any work. Only we will be working. That will be really good.
Absolutely right. Yes.
And,
yeah, Rajul ma'am, you have come. Yeah. I think, madam, that is very important, because the indications has to be there. And actually, I am a MP state ART board member also, and the PCP&AD. Actually, ma'am, the PGT is seen by the officers in the view that whether you're doing sex determination or not. So they want a clear-cut, very strict indications for the PGT. So once it is clear, then I think the government will come with that.
Yeah, so I think I want to thank. There are so many in the audience, who are sending me. They like my talk, so I'm really blessed, Anu, for giving me such a tough topic. I don't know whether you are my friend or dushman. Thanks, because
No, madam, yeah, ma'am, you have started a visionary, madam. See, I told you, ma'am, you have got come a vision. So after returning from USA, you have got a vision, and this vision we are going to utilize in our Indian aspects, because India, in the beginning, that Rishikesh Paisa told that India is going to now rock all over the world, because we have got the maximum patients of the infertility. So once we go to Figo and all, we are going to rock. Yes, ma'am.
Thank you so much. So nice seeing Monica, Ashwini, all my dear friends, Pesi, Anu. I'm going to leave because really I'm not well. I had told Anu I have fever and all that.
Okay, madam. As we are running short of time, we will go to the next session.
Okay, thank you.
I think next we have got an interesting topic by none other than Dr. Ashwini Kale, AI for Semen Selection, Hype or Hope. Before that, we will introduce the chairpersons. Can you show the slide? CV slides? Okay. Can you show the CV slide of Neelam madam? Okay. So we first chairperson is Dr. Neelam Moheri. Madam is a fertility consultant, gynec laparoscopy surgeon, and took a German diploma in ART and certificate from ART from South Korea. She is the medical director of New Life Hospital and Advanced Fertility and Gynec Laparoscopy Center, Varanasi, chairperson of ISAR UP chapter, and secretary UP IAG, vice president of Varanasi Menopausal Society, and past president of VOX. And she has done various publications, national journals, and chapters in many books. And she has got many awards and recognition. And also a good organizer in organizing National Conference of IAG 24, ISOPAR, IMSCON, ISAR SPAT, IAG, ISAR Regional, and lot of workshops. And second chairperson we have is Dr. Priyangur Roy. Priyangur, can you show the Priyangur CV? Priyangur is the one of the most vibrant, young and energetic committee chairperson in Foxy. He is an associate professor of Lord Buddha, Koshi Medical College and Hospital, Shaharshak, and consultant in fertility and gynec endoscopy in Royce Multi-Specialty Hospital at Ramakrishna IVF in Siliguri. As I told, he is the chairperson, Public Awareness Committee. It was one of the selected as the best committee of the Foxy in the last year, and just 2 days back. And is the president of all world president of WATO, that is Young Gynecologists Association. And
sir, will do, sir. Thank you so much, sir. Yes, sir, will do. Thank you so much.
Okay. Next we have our another young and vibrant Nishad Chimote. He's the director of Embryo Lab Evolution and second vice chairperson of Embryology ISAR present, and executive committee member of ACE present, and also scientific committee member of ISGRA, and also joint secretary of IFS Vidarbha 2018-20. More than 2 decades experience in embryology. Chairperson, champion of ISAR Award 2020, ISAR Excellence Award in 23, Best Debater in 2022 IFS Fertility. Areas of interest, as you all know, is lab design. Has designed more than 30 labs across India. That shows his experience and knowledge in that field. And total quality management of AI in embryology, PGT, blastocyst culture, and many publications. And over to chairperson to introduce our speaker. Please show the CV of Dr. Ashwini Kale.
Very good evening to all of you. It's really very wonderful to be here, and thank Dr. Anu and Dr. Fesi for inviting me in this very intriguing this Catalyst webinar. The topics are really very interesting. And today, now we are going to listen about the role of AI in sperm evaluation and sperm selection. And we know that sperm evaluation is a crucial factor in contributing the success of ART. And we have faced a really a daunting task in selecting a single sperm from millions of sperms based on various parameters. It is really time consuming and subjective also. But if we have this AI algorithm in place, then it could revolutionize the field of medicine and the sperm selection. It will address the challenges in this sperm selection with their large data processing capabilities, and high objectivity will be there. So we have to have more data with that. And now I invite Dr. Ashwini Kale for the talk on AI in sperm selection. Dr. Ashwini.
Thank you, Neela. Yeah, thank you, Neela ma'am, for introducing the topic. Yeah. I would like to introduce my very good friend, Dr. Ashwini, for this talk. So Ashwini is a consultant Asha Kiran Hospital in Pune. She's the managing committee member of ISAR Embryology and a past treasurer of the MSR. She's the ISAR Vice President for Pune OBGYN Society, and she's currently elected as the Joint Secretary for the incoming Foxy year as well, for which I wish her all the best. Ashwini has been a brilliant orator, and she has done many talks, and with her and her, of course, husband, who's also a very dear friend of ours, Dr. Ashish Kale, we have done many programs together, and it has all been huge successes. So Ashwini, I'm sure your talk on AI is going to enlighten all of us regarding this upcoming topic, and I'm sure we're going to learn a lot from the same. So over to you, Ashwini, for your talk on this exciting topic.
Thank you so much, Priyankul, for the wonderful introduction, and heartiest congratulations for winning the Best Committee Chair at Foxy. We are very proud of you. First of all, I'd like to thank Amit Patki sir for having me here and for conceptualizing this entire concept of the ISAR Catalyst series. Thank you, Anu and Fesi sir, for this. So the topic for today is AI for sperm selection. Is it a hope or hype? So I think suddenly all the attention from oocyte and embryos has come back to the million sperms to select one amongst the best. I think previously it was just the semen analysis that we would do, and whatever the result was, everybody had an answer to it that kuch nahi hai to ICSI to hai hi in the end. Come what may the result of the semen analysis, whether it was a mild, moderate, or a severe odds, ultimately the answer was ICSI. But today we have a very, very good modality to actually choose that one best sperm to make a very good embryo and probably an euploid embryo, and ultimately increasing the pregnancy rates. So how do we describe this AI in one word? And I actually see this AI everywhere. Initially, when we used to do Zoom, there was never this AI companion option there, but now I see this AI even here. So I think we are just day in, day out breathing in AI now. So this is the timeline that I would like to talk on. So how this AI came into it. Way back in 1936, Alan Turing published the computable numbers. Then over the decades, a model of backpropagation was started. In 93, the support vector machines came, which basically started all these algorithms. Then 2001 was the birth of the first cryopreserved embryo, though in 92 we had invention of ICSI, which was the only solution till date for a bad semen sample, or the only choice for the sperm. And then in 2013, we saw the development of time lapse with all its limitations also and the advantages also. So what is this AI basically? It is nothing but a current approach to medicine, which uses all the machine learning algorithms to predict the success of therapeutic procedures. And it basically assists the clinician in the decision-making process. To date, machine learning studies in the andrological field have mainly focused on prostate cancer imaging and management. And this is where AI has come out very hugely. An increasing number of studies are also being documented on the use of this AI, which assists the clinicians in decision-making and patient management in andrological diseases such as varicocele and sexual dysfunction. So it is that branch of engineering which is basically attempting to model intelligent behavior and solving complex problems, which uses computers, minimal intervention of human intelligence. And in recent years, this research on the use of AI, it has grown rapidly in all health fields. Initially, we thought it is only for the engineering field, but now it has come in a big way in the healthcare as well. So this AI is basically distinguished into two things. One is your virtual branch, which is the machine learning, which uses the mathematical algorithms and improves learning through experience. The other is the physical branch, that is the robotics, which has already been used probably from a decade earlier than this virtual AI, wherein the surgeons take the help of these robots to do surgeries or monitor the treatment. So one of the important and the early applications of this AI in male infertility has been CASA, which is the computer-assisted sperm analyzers. They are considered useful tools for the rapid analysis of many samples, and it actually allows a reduction in inter-operator variability with a high reproducibility. It also provides a more accurate measure of sperm motility and kinematics. It basically all depends on the sperm motility. So the four parameters which it actually studies is the curvilinear velocity, the straight line velocity, lateral head displacements, and beat cross frequency. So everything is dependent on the amplitude, and that is how the AI detects the best quality sperm. Now the limitations of this CASA is that it still doesn't allow them to replace the human operators. I'm sure Nishad here would agree that even though we do the semen analysis in CASA, we still have a habit of doing the physical semen analysis, because that has not gone yet, because that is how we still see the morphology and other physical characters. So this includes lack of standardization and poor accuracy in assessing the sperm morphology. And it is highly complicated, or probably it still doesn't give those kind of results when you have a sample with a higher viscosity, severe oats, or in presence when there's many round cell debris or agglutination. It even at times gives you false results in cases of azoospermia. The results are basically affected by the type of slide preparation, chamber depths, the loading method, and the representative of the evaluated fields. So this is why even WHO in the 6th manual in 2021 has recommended CASA as advanced tool for examining sperm motility and kinematics. And it has still not said that your physical or manual semen analysis has totally to be replaced by CASA. Furthermore, this AI, it has been used in the evaluation of lifestyle and environmental factors, which basically predict alterations of human fertility, demonstrating, for example, they use characteristics such as the age, alcohol consumption, cigarette smoking, sedentary lifestyle, and they're more effective at predicting an alteration in future fertility than actually of the patient having any childhood illness. So if you just put these 4 or 5 parameters in that algorithm, you can actually predict for the male whether that he will have infertility or subfertility. Machine learning algorithms and deep learning methods have been developed to predict the sperm with a high DNA fragmentation rate, which is a known cause of male infertility and ART failure. Now we are into a lot of doing DNA fragmentation index for many of our patients. So AI has even touched this by its use in the flow cytometry. It evaluates the biofunctional sperm parameters, which basically includes DNA fragmentation, mitochondrial membrane potential, the oxidative stress, and the membrane peroxidation, because it is at this level that the damage occurs, and that is how it gets reflected in the DNA fragmentation index. To date, there are software programs such as Flojo and Cytobank, which includes machine learning tools such as concatenation, SNEs. SNE is nothing but it is a software which is used to decipher very complex algorithms and clustering. These are all the methods that the AI uses. This is basically an AI language, which allows the analysis of this flow cytometry data at a single cellular level, offering useful information on the biology of the sperm function. So we are going towards knowing what exactly is the problem at the cellular level. For example, there is a study through the creation of an ANN trained with 12 features, which include the woman's age, the total dose of gonadotropins administered, endometrial thickness, and the number of top quality embryos. And it actually showed a very high sensitivity and specificity in predicting live births. Imagine you sit in your clinic and tell the women, depending on these 5 parameters, that you have a chance of having 76% live birth rate. So which is really huge. Just one sec. I think I need a charger. Sorry. So furthermore, the role of AI in selecting spermatozoa to be used in ART appears promising. Indeed, it has been demonstrated that these deep learning methods have high sensitivity and specificity in selecting which predicts having a top quality embryo and ultimately a live birth rate and a pregnancy. AI is also useful in assessing the sperm motility with CASA system. So that is why they press upon looking at the motility rather than the morphology. Therefore, the use of an integrated approach mediated by AI, which takes into account all these parameters simultaneously, it could constitute an important tool for embryologists to select the best embryo. This in turn would result in an improved pregnancy rate and a live birth rate. So do you think that time has come that probably embryologists would be replaced by this entire AI thing? I still feel that it won't be, because ultimately you would need a man behind the machine to assess it, to read it, or probably even correct it and improvise it. Sorry, I went on the last slide. One sec. I'll just share it again. Video isn't playing. Just give me a minute. I don't know why my other slides are not seen here. 1 second. Just give me a minute. ड्राइवर के साथ the video is suddenly not playing.
Even his team, can you help Dr. Ashwini?
No. Actually, it is my PPT problem only. It's not showing the videos. The videos are not being played. It is a problem with my PPT.
Me or I can try on WhatsApp if you can share me.
No. That my videos are only not playing. I'm really sorry.
Okay. Sure.
Yeah.
She hasn't incorporated AI into her PPT yet, so that is why
that's
a problem for her.
Probably I need to improvise on it now.
Is it with only that one? this thing slide or it's with all the other videos? Okay, got it.
Yeah. So basically, this is how a smartphone-based semen analyzer looks like, and actually the cost of it is just less than $5. So probably it is even cheaper than having an embryologist do it. So introducing this AI facilitated sperm detection tool in azoospermic samples is very useful, because what we actually see manually or physically in azoospermia is all the sperm look the same, but ultimately selecting the best of it depending on the morphology and the motility would ultimately improve the results. Thus, this reduces the physical strain and fatigue on the embryologist, because you can see an embryologist sitting in the lab for hours together, probably even 4 or 5 hours, looking at an azoospermic sample. This is a highly transferable clinical tool for the treatment of severe male factor infertility. Now, coming to the use of ICSI. So this is how the advantages of AI in sperm selection is, wherein it selects the good, medium, low, and the best sperm. So you just have to place the needle inside the circle to rank the sperm, and then it gives you the grading A, B, C. So it is more like playing a video game in your embryology lab, and plus wherein you get good results and also you get paid for it. So this is one more example of it. When you see the prepared dish sample, but again, this dish has to be manually prepared by the embryologist. So you can see here that it's going to be A, B, and C, the grading. But ultimately, all of this depends on the motility or the kinematics of the sperm. So that is ultimately very important. So this is how automated ICSI has come into place now. And I believe at a recent conference in ACE here in Pune, people have also seen the demonstration of Robo ICSI. So I think there's time wherein the robo can ultimately and automatically select the sperm. So here you get all the options of going to the sperm droplet, immobilizing the sperm.
और कोई तकलीफ इसके अलावा स्पॉटिंग हुई है?
So this is how you select it and do the automated ICSI, wherein you just have to select, go to sperm droplet, immobilize the sperm, needle in the pickup position, load the sperm. So it is more of like an SOP where you just do the click, 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 and the ICSI is done. And it is just a matter of few seconds. So this is about the oocytes. So I think AI is definitely here to stay, and it is not only useful in ICSI, but it actually gives you a very good algorithmic table where you can predict the fertility for the male partner, and you can actually tell them whether this patient with all these factors can still have infertility and which is the best sperm to be used when you have cases of azoospermia. So thank you so much for your patient listening, and sorry about the slide thing.
Ashwini, that was very nicely done, very good talk and very comprehensive. And I'm very happy that you have covered the latest technologies, especially the SID and the CASA systems that are available. I would like to add one more thing. Recently, again in ACE, the same group, the talk was by Dale Goss, the guy who was in that video for that SID.
Correct.
So they have also come up with software called SMOS, which can detect sperms in your TISA and micro TISA samples.
Exactly.
So if an embryologist, he takes around 3.5 hours, they are trying to find 1 or 2 sperm in the same time. This software helps you to identify 9 to 10 twitching sperms. So it has reduced the time to half. So
Correct.
yes, AI and
so now there is
especially the
even a very good algorithm which can actually tell you in a patient of non-obstructive azoospermia about what are the chances of sperm extraction. And when you extract that sperm, what is the chances of that sperm forming a euploid embryo, not only an embryo, but an euploid embryo. So I think all these algorithms within few minutes could actually tell the patient their probability of having a sperm extraction, the morphology of the sperm, making an embryo and getting a pregnancy. So I think, yes, in another 10 years, probably we would be sitting here and doing ICSI at the click of a button.
Yeah, I mean, even
from
that
Robo ICSI, we are going to a remote ICSI now. So
True. I
yes,
think
it
that
is
also,
there.
I think we will discuss that also, the Robo ICSI, it was more of a satellite ICSI, I would rather say, that you can sit in your center
and that software and internet is there in another center where the junior embryologist is just preparing the dish.
Exactly.
And you can do ICSI on a screen like your maybe a mobile phone or a touch screen. And you
So
can
they
just
are
do
trying to simulate the robotic procedures, the robotic surgeries, how they are done in this robotic ICSI also.
Right. So that way you can select the sperm. The only problem I think, which I think if you can spread more light on is like SID, it's the flagellar movement and the motility of the sperm that is used. But then again, we know that it's almost like IMSI somewhere that you're going for morphological selection of sperm. But we also need to understand that it does not guarantee us good implantation rate and maybe a higher live birth rate. Because the problem here is we don't know how the DNA of that sperm is at the end of the day. So yes, these processes are, or the softwares or AI softwares are good, but they are not as promising as if you compare it to any new. I think there are certain which are still in experimental phase, which can determine the DFI and then you select the sperm. So that is where we
Probably
should.
it is an integration of too many things into one and then providing an algorithm and then coming out, because it's not only just sperm selection where it stops, then you again go in and do this AI algorithm with the embryos also. And now the AI algorithm actually selects the euploid embryo. I mean, with that US said the algorithm that has come in. So probably you might not even need to do a PGT.
Yeah, I mean, NIPGT also, like this point of view, the last conference that we saw, I think NIPGT also will be a thing of the past in next maybe 3 to 5 years. It will be completely optics and time lapse and AI that is going to select embryos for euploidy and aneuploidy. So definitely,
so I think it will be a matter of the man behind the machines with a lot of screens there, too many algorithms, and then ultimately predicting it.
Yeah. So I think like how there was an era of embryologists who used to, like, we used to know how to make media, we used to do a lot of stuff. Now generation, they don't know how to make a media. The next generation will not be even doing ICSI. They will be doing something else. So embryology will be there, but the job profile will be different. So yeah.
Probably it will be a PS4 of embryology now.
Yeah.
Wonderful lecture, Ashwini. So man behind the machine is very important.
Very nice, very comprehensive and crisp and interesting talk, Dr. Ashwini, and really I enjoyed very much it. And we know that AI is the future. So everywhere in our life it is coming. So why not in IVF and ICSI and sperm selection? Thank you very much. Very nice.
Thank you, Ashwini. That was a
Thank you. Yeah, thank you, Ashwini, for the wonderful talk.
Nishad, Neelam madam.
Thank you.
Yeah, and thank you on behalf of Neelam ma'am and Nishad. Also, I would like to thank Fesi sir and Anu ma'am for giving us this opportunity to chair this session. And Ashwini, it's always a pleasure listening to you. Thank you so much once again.
So coming to our next session, panel discussion, ovulation induction protocols, what is new? And our moderator is Dr. Monica Jindal. Thank you, Dr. Monica, for accepting my request. At 11th hour, you accepted my request. Actually, Dr. Seema, she was sick. So only 2 days back, I requested Dr. Monica to conduct this panel. Thank you. Thanks a lot. Dr. Monica, she is consultant reproductive medicine, Bhopal Fertility and Endoscopic Center, Professor, Allen Medical College, Bhopal. So I'm leaving all this because we are running short of time and we all know you, Dr. Monica, very well.
Okay, Anu, I'm so glad to be here in the program. And we would, I'd really like to thank the whole of the Central ISAR team for having me here, especially my dear friend Anu. And so should I begin, Anu?
Yeah, sure.
Yeah, so before I begin,
introduce the panel members.
Yeah, I will introduce the panel members and then we can start the panel. My first panelist, though she has sent apologies to us, is Dr. Sayali Kandari.
She's told she's not well.
Yes, she
fever.
has a fever, so she is not there. But we all know her as a very dynamic embryologist and geneticist, and of course, a member of our managing committee, embryology. And next panelist is Dr. Akriti Gupta. I think Akriti, is she there? Akriti, I think
Yes, she's there.
is there. So she is done her fellowship in reproductive medicine from FRM Craft Institute of Kerala. She is assistant professor OBG at Sri Mahant Indiresh Hospital and Medical College, Dehradun. And of course, a great academician, a very, dynamic and young reproductive medicine specialist. Welcome, Akriti.
Thank you, ma'am.
And next, I would like to introduce Dr. Mitali Gupta. Dr. Mitali has been keenly listening to the entire webinar, I could see. So she is Associate Consultant Reproductive Medicine at Neelkant Hospital and Fertility Center in the Pink City of Jaipur. Welcome, Dr. Mitali. Next, I would like to invite Dr. Purnima Tiwari. I think she is the Young Brigade of ISAR, and
Yes,
she belongs to my own city, Bhopal. She is again a very dear friend of mine. She is consultant OBGY at Purnima Gynec Fertility and Ortho Center in Bhopal, and also a visiting consultant at Apollo Sage Hospital, Bhopal. She has got a very distinguished CV, alumnus of MAMC Delhi, received several awards like Foxy Traveling Fellowship, and also received the Dr. Manish Banker Young Achievers Award in the annual ISAR conference of 2024. Welcome, Purnima. Next, I would like to invite and welcome Dr. Soumya Mathur. Again, Dr. Soumya is, from Jaipur. She is OBGYN, IVF specialist at Mangalam Hospital, Jaipur, and IVF trained by Foxy at Nimaya, Ahmedabad, and also has done masters in gynec endoscopy at JDH, Jaipur. She is again an avid writer, has published papers written in various journals, alumnus from Rajasthan. Welcome, Dr. Soumya, to the panel.
Thank you, ma'am.
Next, I would like to invite welcome Dr. Anuradha Pancholi. Is she there? I did not see her in the program. I don't think she is there, but Dr. Anuradha Pancholi is again from Madhya Pradesh. She is a young brigade, a member of ISAR, and belongs to the city of Ujjain. So we start the panel. I think we are now here with Akriti, Mitali, Purnima, and Soumya. That's it. So you are all, likely to be hit very frequently because there are only 4 of you. So I start with my. Can you see the slides?
Yes, ma'am.
Yes.
Right. So we start with ovulation induction protocols, and after listening to the hi-fi topics of AI and NIPGT by distinguished speakers, we come to a very grounded topic of ovulation induction. But all said and done, this is what we do. So rest NIPGT, we might not be doing day in and day out. And, AI in the embryology lab, we might not be doing that often. But of course, we'll be doing a lot of ovulation induction. So just to introduce the topic, we know that infertility brings a lot of distress in the couple's life. And what is the problematic portion is the long-lasting, time-consuming, and sometimes, poor result treatment. So this couple is forever agonizing between hope and despair, expectation and frustration. So when we start talking about IVF, we should know about stimulation. And we know the history of IVF started with a natural cycle IVF. Louis Brown was born out of a natural cycle IVF, and it was a single oocyte retrieved transabdominally, fertilized a single embryo, and the baby was born. So here we started the concept of ovarian stimulation. The concept of ovarian stimulation was aimed at, number one, eliminating the risk of having no oocyte at all. Number two, improve your results by obtaining several embryos and then selecting the best quality embryo. That time the embryo was selected morphologically. Now we have PGT and all that. So that is the reason this concept of ovarian stimulation developed. We should also know about basics. So we'll start with Akriti. Akriti, could you tell us the basics of ovulation? Why does the follicle grow in response to the HPO axis? Why does every month only one follicle grows? And why does in superovulation multiple follicles grow? Just explain it to us.
Okay, ma'am. Thank you for the question, ma'am. See, if we have a normal menstrual cycle, so what happens is we know the stages. We know that there will be a stage where the pre-antral follicles will be there, the antral follicles will be there, which will start producing FSH. And then out of those antral follicles, one will have a higher concentration of FSH receptor. Also, as a result of which, the estradiol in that particular follicle would be at a higher stage, as a result of which it would be selected and forming a dominant follicle. So that would be a natural cycle, right? However, when there's a superovulation cycle, so it works on the process of, FSH threshold, and it works on the process of
Positive
yeah,
feedback.
positive feedback, wherein if you, like, I'm forgetting the other term, FSH threshold and FSH, one more is there, which has that, I forgot the term, which we use for step up and step down protocols.
Crossing
So,
the FSH.
yeah. So in this, what happens when you're doing super ovulation, if we are inducing the suppose either it is clomiphene or it is letrozole. So like letrozole has a monofollicular growth and clomiphene has a multiple follicular growth because of the persistence of high FSH for a longer time. However, similarly, if you have gonadotropins, so in that, when we are putting the gonadotropins for a longer time, like 2-3 days continuously, so it crosses all these follicles which are growing, the antral follicles. So each has a separate threshold. So they keep on rising.
Absolutely, absolutely. Akriti, I think you have hit the point nicely, and you are absolutely right that you have to cross the FSH threshold for multiples of follicles before you call it superovulation. And that is what we are achieving by ovarian stimulation. And this pool of primordial follicles, how many days it takes to reach that antral follicle? It takes nearly 7 months, 200 days. So that is why this concept of waves of folliculogenesis has come. That is why you are having random start protocols. And the cyclical recruitment has now been converted into something you can manipulate in your ovarian stimulation regimes. And that is why you can, preserve oocytes. You can do fertility treatment. So next, I would like to ask Soumya. Soumya, how do you classify a poor responder? In fact, tell me what types of patients you have in your OPD. What types of patients are there who walk into your OPD and they want ovarian stimulation? How do you classify them?
So, ma'am, mostly these days we are seeing patients with low AMH. Very young patients with premature ovarian insufficiency are seen, and so we have to really, like earlier it was more of PCOS, so we had to go in for an anti cycle and we had to take out OHSS. But these days we have more patients with low AMH of 0.5, 0.4. So that is what we are seeing these days.
So, sorry, I had to take a call. Soumya, you finished answering?
Yeah, and the classification, if you're asking, I think you're asking about the 4 types of ovulation, that is starting from hypogonadotrophic hypogonadism and
No. I'm not asking you that. I'm asking you, how do you classify your patients who are starting ovarian stimulation? They are not responders.
They can be high responders,
and
responders, or low responders, depending on the AMH and various other factors.
Yes. They are only basically, it's a very simple question. There are 3, categorize the patients into 3 categories before you start the ovarian stimulation. Contemplate
Yes.
ovarian. So, how do you actually classify a poor responder, or how do you define a poor responder? Which patient would you call a poor responder? What are the criteria you used, and how do you stratify these poor responders?
So poor responders, we use the main criteria is AMH, in which when the AMH is less than 0.5, we consider them as poor responders. And also AFC, that is the antral follicular count on day 2.
Can you tell, Purnima, can you tell us something about Bologna criteria?
Yeah, ma'am, in the Bologna criteria, when it was proposed, the Bologna that made basically it had these three options, and one of the feature has to be present to classify the patient as poor responder. Like it is already written advanced maternal age, previous poor ovarian response with conventional protocol and abnormal ovarian reserve, AFC 5 to 7 and AMH 0.5 to 1.1. Then further, the Poseidon criteria was given because it was not the patient base. Basically, all the patients were categorized into these three, classified according to these 3 points. So the further
Bologna criteria was subject to severe criticism because Bologna gave a blanket definition for all poor responders. It did not take into account it did not stratify according to previous IVF cycle, according to the antral follicles, according to, the age, according to the AMH. Now the AMH is also come. So this Bologna criteria still stands. You have to have, at least 2 out of these 3 features positive, like Rotterdam's criteria. In Rotterdam's for PCO, we followed 2 positive out of 3 to be called Rotterdam's PCO. Similarly, in Bologna, 2 out of these 3 have to be positive, and there has to be a previous conventional stimulation protocol to which the patient has, been subjected to before saying she had a previous ovarian response. Now, Poseidon criteria is actually not a diagnosis criteria. This is stratification. So who can describe Poseidon for us, Dr. Mitali?
Ma'am, in Poseidon criteria, we have 4 groups, group 1, 2, 3, 4. So, group 1 में young patients, मतलब age less than 35 years we consider, then suboptimal or low oocyte number. Then group 2, old, I mean more than 35 years of age and with suboptimal or low oocyte number, मतलब 5 to 7 AFC per ovary.
To describe, it is just like basically you have to see the main features. Okay, then tell me, Mitali. So 1 and 2 are basically we call them unexpected poor responders. See, in 1 and 2 groups, these are the women in whom you sometimes do not even expect they'll be poor responders. But when you do the first IVF cycle for them, see, they have got less oocyte retreat. So they are the time bombs, the unexpected poor responders. Whereas groups 3 and 4 are the young and the old who are expected poor responders. You don't have to subject them to IVF in order to find out the response because you already know. So which is easier to treat? It is
group 3 and 4.
Because you know that they are there.
We can
Use your
predict.
maximum, skill in order to get them stimulated and get the required number of oocytes. Now, can somebody tell me which makes up the maximum bulk in your OPD? Out of 1, 2, 3, 4, which is the maximum bulk in your OPD, more than 70% patients?
I think, ma'am, 1 and 2. The 1 and 3, I think. 1 and 3, probably.
3.
So this is strict criteria. The slides are there on Google, everywhere. The maximum number is present in group 4.
Okay.
Elderly patient who are known poor responders. Now imagine in your clinic, it might vary from place to place, but maximum patients who are poor responders, they have crossed the age of 35. They come to you with AFC less than 5. They come to you with AMH less than 1.1. And they are the ones, who are coming to your treatment maximum because they have no other option. Group 3 will be still struggling. Group 1 will not even know what to do. Group 2 is somewhere in between. So the first most common group is group 4. Second most common is group 2. That is, the elderly patients are the ones who take fertility treatment the earliest. The group 1 and 3 ignore the risk of the treatment or the risk of whatever they are going through because they basically don't know what they are in for. But the good thing about 1 and 3 is that they are the relatively younger patients. So that is why you can see on the right side, the pink diagram, these group 1 and 3 have got low embryo aneuploidy risk. Whereas whatever you do, group 2, group 4, whatever treatment you might give, whatever adjuvants you might give, there is a high risk of embryo aneuploidy in the group 2 and 4, which also makes up nearly 80% of the total patients walking into your OPD as poor responders. Okay. So that is it. Now, please tell me, Akriti, which patient do you classify as a hyper responder and why? Akriti is there? Okay, Soumya, you can take this question.
Yeah, I'm there, ma'am.
Okay, Akriti,
I'm
so
there.
which patient do you
Yes,
call the
ma'am.
hyper responder and why?
Ma'am, a hyper responder will be somebody who show exaggerated response to stimulation. So they primarily have an AMH which is more than there are ranges like 4 probably, and who have a ovarian reserve, the AFC, the follicles, if they are more like they're more prone to OHSS. If they are more than 11 follicles, at least more than or equal to 19. So the 19 follicles are more than equal to 11 during the stimulation, they would be probably a hyper responder. AMH more than 4 or 3.85, that is the cutoff somewhere in the ASHRAE guidelines also. So then there are other predictive factors of hyper responders, like thin body weight, previous past history of a hyper response during ovarian stimulation cycles like IUI. Those
Now the thin body weight thing has gone because
no,
now
ma'am, risk factor, just the risk factor for
no,
a
no,
hyper response.
even a
Okay.
risk factor because now the PCO has been divided into phenotypes.
Yeah, A, B,
That
C,
is
D.
another. Now PCOS phenotypes are there, A, B, C, and D. The PCO phenotype which is most risk to hyperstimulation is A and B, and the mildest phenotype is type D. So I'll be taking that target for you again.
Okay.
Don't worry, because that is the panel discussion, very extensive.
Okay.
PCO phenotype.
Fine, ma'am.
But the important thing about hyper responders is that when you give them conventional stimulation dose, conventional dose is 150 to 225 according to guidelines, they hyper respond, and as you said correctly, they grow follicles more than 18 to 19. So Purnima, who is a normal responder? You have come to know who is a poor responder, who is a hyper responder. Who do you call a normal responder? Purnima.
Ma'am, the normal responder, basically the patients who responds, who have the AMH level within the normal range and also the AFC count within the normal range, and who will respond as we have already predicted that they will respond normally with our stimulation protocols.
Okay, so this is basically predictability. Sometimes some normal responder may show exaggerated response. Some may show unexpectedly poor response. But whenever they are expected or predicted to be, proper AFC, proper ovarian volume, proper response to a conventional dose of gonadotropin, you call them a normal responder, and we'll see in the cases. So I think we start with the first case with Dr. Mitali. So Mitali, this is Mrs. Normita. I have made the names very simple so that you can know. So Mrs. Normita is basically a normal responder. She is 35 years old. She has come for the first time in your fertility clinic, married life of 8 years. She has a BMI of 22. She has AMH of 2.2. She has AFC of 8. So all is very good. But when you take history, you find out that this lady had pleural effusion at the age of 18 years. I think in the north of India, they call it pasli mein pani bharna. They will say typically pasli mein pani bhar gaya tha. So this is age of 18 years. She took ATT. But when you do a laparoscopy for her, you find dilated tubes, bilateral chromoperturbation is positive. And this lady has also undergone multiple failed IUI cycles in the level 3-tier city where she has come from. Now she has come to you with a normal semen analysis in this history. How do you tackle her?
Ma'am, first of all, we'll explain the risk factors associated with her. First is the history of tuberculosis. For that, she took ATT. So there will be chances that endometrium would be thin. So we'll assess on TVS both ovaries for AFC as we have done, plus endometrium. Also, we can suggest her laparoscopic delinking because as the tubes are dilated, so possibly there would be hydrosalpinx visible on.
So at the time of laparoscopy, you took permission for delinking, but the patient refused. Her husband also refused. They said tubes खुले हुए हैं, madam, हमें delinking नहीं कराना.
But
so you continue as नहीं, you can't do anything without consent. You have to take that into consideration. And the good thing is it is an open hydrosalpinx or something, or a very mild to moderate. So it is not having that collected fluid, which is more dangerous when it goes into the uterine cavity and flushes.
Yes, ma'am.
And
It is embryotoxic.
a dilated tube is less dangerous than an encysted hydrosalpinx. Okay. And second thing is that she has taken her ATT very nicely, and luckily endometrium was not affected. So when you see her mid-cycle, you see a nice endometrium of 8.2 mm at day 12. So you are happy. Now you have to plan a cycle for her. What do you do? These are the guidelines we are following. I have already given in the group. So these are the ESHRE. I searched all over literature. It is only ESHRE which has given proper ovarian stimulation guidelines in 2019. And after that, COVID came. So I don't think the guidelines were revised. And anyway, the guidelines are so beautiful that we don't have to, bother about it. So tell me, in this patient, Mitali, now we'll go stepwise. How do you plan your strategy? You already know she has got AMH of 2.2 and she has got AFC of 8. Would you assess her with some other measurement before starting the stimulation, or would you just proceed? What do the guidelines say?
Detailed 3D scan, detailed 3D vaginal sonography, transvaginal sonography is to be done.
Suppose you don't have 3D scan, you won't start the stimulation.
Ma'am, we can start.
Ma'am,
Yeah.
we'll also see one more thing I would like to add.
Yeah.
Ma'am, I think the uniformity of the follicles, they should be coherent in size.
Yeah.
Homogeneous.
So we will not like to lose any follicle for her. She's already having 8.
Okay, any comments on AMH? Suppose you have a beautiful AFC of 7 to 8 follicles, 4 in each ovary. You have got a thin regular endometrium. You have got history of properly taking AKT. You have got an AMH of 2.2. So you can proceed directly with stimulation.
Ma'am, after the ATT, was any this thing, what you call TB endometrium or anything done?
Everything done. Everything fine.
So yes, ma'am, we can start. Everything is normal.
So there is a strong recommendation. What I wanted to emphasize was, though I have given AMH to you, suppose this patient had come to your clinic from a village and she did not carry the report of AMH, but still she had good AFC.
Yes, we can start.
Yes, ma'am.
You can proceed
Yes,
with
ma'am, we can start.
AMH. So the guidelines say you can use either AFC or AMH to assess the ovarian reserve. There is no need to burden the patient with an additional of AMH. Okay. So another thing is that at the beginning of the stimulation, we sometimes, start by doing these 3 tests. What does the guidelines say about conducting a test for estradiol, E2, LH, and P4 at the start of stimulation? You're also starting ultrasound. You're also taking a blood sample. Is it mandatory to take a sample at all?
No, ma'am. Only if we have a doubt, if we see any follicle more than 10, if we see the endometrium more than 5 mm, then only I think we should go for an estradiol. Otherwise, patients might not be able to afford the blood tests every time. If you're a single user, single person doing an ultrasound, I don't think there would be a need to.
Akriti, leave the affordability. Yours is a charitable clinic.
No, ma'am, no.
No. I'm just giving you example.
Okay, example.
I have a charitable clinic. I get funding of 50 lakhs per month for my IVF cycles. Okay. I will not do E2 LHNP because it is not evidence. It will not add to my diagnosis.
Correct.
Properly done baseline ultrasound monitoring is sufficient. If you have got a good history, you have got a good scan, no need to do this E2, no need to do P, and no need to do LH. Okay. And another thing is, you are stimulating her, and you have probably, what is the best type of dose which you will select in your clinic? We'll go to gonadotropins later. Suppose you are stimulating her with the highly purified FSH.
Ma'am, what was her age again? What was her age?
35.
30. She's 35. Yeah. She's the watershed line 35. And she's married for 8 years.
Ma'am, if she's
150, 75.
But her AMH is 2.2, Akriti. AMH is 2.2. AMH is not less. Is not less. What dose of highly purified FSH or HMG or recombinant FSH? Everything is the same.
Select. 150 Folisert, 75 Menotas.
Okay. Right. So you'll choose a dose of around 225.
Yes, ma'am.
225.
Okay, so you are doing her continuous monitoring and you have beautifully, a beautiful cohort of follicles growing. Now, suddenly you have to start an ANTAC in a flexible manner. Would you like to do an E2 measurement or would you like to do E2 monitoring during the cycle 2-3 times if the patient can afford?
No, ma'am.
No, ma'am.
So,
I don't
again,
do. We not do.
again, your main armamentarium is your ultrasound machine. If you're getting good follicles and the follicles are growing and causing an endometrium to grow beautifully. The endometrium can only grow when the follicles are producing sufficient amount of E2. Okay? So if you're getting a good triple line endometrium by day 5, 6, and suddenly there is a time when the endometrial thickness jumps. It suddenly jumps from 3.5 to 5. That is the day you have to start antagonist. And as a senior reproductive medicine consultant, I would strongly advise all of you not to have a fixed antac protocol. Have a flexible one. Even one antagonist is around 1,500 to 2,000 rupees. As soon as you give antagonist, the follicular growth, it, goes down a little bit. So try to start your antagonist in a flexible manner and do your ultrasound monitoring very stringently. So I have made the point clear about normal responders that ultrasound monitoring is very important. Now, Soumya, you tell me, this patient has come to you on day 7 of the cycle. Unfortunately, she missed that window of coming to you on day 2, day 3, day 4. And you want to now time, and she also has these Navratras coming up. She doesn't want to undergo stimulation during Dashera and Navratris. So what will you do to program her for the next cycle? Would you do anything? Soumya is gone. Mitali, you can continue, please. Yeah.
Ma'am, we can start her on endofert for 20 days.
How do you give your endofert for 20 days or from day 7 of patient has come to you on day 7 of the cycle, you have done a baseline scan and everything is okay. A tiny dominant follicle is growing on the right side. On day 7 of the cycle, the follicle is around, let us say, 8.5 mm. One single follicle in the right ovary. The rest of the follicles are okay. And she has come on day 7. And now you want to plan her stimulation after 12th of October. That is after the Dashera. What will you do? Anybody can take the question.
Ma'am, she has come like today. Today is the 7th day. Like this you are telling?
No, I'm just saying that you want to program her for the next cycle.
Means next month, right? Next month.
Anytime next month.
Then it's easy. We'll definitely, we can watch her cycle again, ma'am. We can do her like post-ovulation scan around maybe around 17th, 18th day. Then can put her on Meprate and then she can get a withdrawal.
She doesn't want to stay. She wants to go back to her village and she'll just come on day 2. So what do you do?
Ma'am, we can get the 20 days, 20.
Then I think, ma'am, E plus P would be better.
You would like to give her?
E plus P. If in case she doesn't want to come back for a scan, then E plus P. But if she can come, then I think watching the scan, watching the corpus luteum, and then putting in a Meprate is okay.
Yeah. Ma'am, if at all we want to plan the cycle, then E plus P is better than giving the OCP anytime.
Actually, ENP is something.
OCPs we're not giving
ENP is and OC is almost the same thing. But what do the guidelines say? That pre-treatment with estrogen before ovarian stimulation, if you have an antac protocol, is not recommended. In fact, there was a lot of hype about E2. We used to start the patient on estradiol from day 21 of the cycle for 10 days or something, 8 to 10 days, and then wait for a withdrawal and start stimulation. But nowadays, the guidelines have said it is not, recommended. Similarly, putting her on Meprate before ovarian stimulation is not recommended. And at the same time, the guideline also recognizes that because estrogen and progesterone are used widely for scheduling purposes, they can be done by a specialist. They can be used as a good practice point. So even if you wait for that patient to pass on that cycle naturally, she can come to you on day 2, or you can give the last 10 days estrogen, or you can give the last 5 to 6 days medroxyprogesterone acetate or norethisterone acetate or you can give her the whole cycle E plus P. It doesn't make any difference, but the guidelines say that you don't need to do anything about it. Any comments, anybody? Shall we move
I
on?
think, ma'am, again, yes, ma'am, again, for if patient, like you said, she wants.
Yeah. No,
But
she
I
has.
think, ma'am, sometimes what happens, like many times in my practice also, we usually say, she's having regular cycles, and yes, and you can come on the regular time, when you get your periods, because we have an in-house embryologist. But I think sometimes the patient stresses so much, like, they think about the stimulation, कि उनका IVF होने वाला है, तो ना उनके period ना थोड़े delay हो जाते हैं. I have seen it with 2 or 3 of my patients. ऐसा नहीं है सब में होता है. But then, yes, it happens in some patients.
Actually, it is, I think, ingrained into our heads, Akriti. Like now, I have been doing IVF for nearly 19 years, 20 years. So it has been ingrained into our head. When you give something for cycle programming, you'll get a, good cohort of follicles. You'll not get any cyst. You'll have a predicted withdrawal. So that is the reason.
Yeah, predicted. Yeah, we actually time it with our schedule and
Yeah.
everything,
Yeah.
no?
That
So
is
it's comfortable for us.
okay. That is why the guideline development group has taken it as a good practice point that if you're using ENP, that is, good enough. There is nothing which you're doing wrong. Okay. That is as far as this is concerned. But somebody was mentioning COC. Pre-treatment with COC, especially with ANTAC protocol, is a strict no. Because with ANTAC protocol, if you do programming with COC, like
those increases.
Mala or Asmita, overall, whatever, you're going to reduce the cohort of follicles. The body really gets suppressed. So don't use COC, especially with an ANTAC protocol. And again, there is a school of thought that instead of starting ANTAC from day 5 or 6, you can start ANTAC from day 2, day 3. And then start stimulation. That gives you a uniform cohort of follicles, but I don't follow it. If any of you has got experience with GnRH antagonist pre-treatment before starting ovarian stimulation, you can please share with us. This Dr. Jatin talks about it a lot. Dr. Jatin often takes lectures on poor responders. So this is one of his favorite therapies. He talks about starting ANTAC from day 1 or day 2. And
Yes,
then
ma'am, for 3 days.
yeah. And then
for 3
he
days.
starts the gonadotropin.
Ma'am,
This is also mainly for scheduling the cycle. Suppose if the patient gets periods earlier than the expected time, then they start citro for 3 or 4 days just to continue the cycle.
Or if your first scan falls on Sunday, so that just to escape that day.
Yeah.
And also, ma'am, if we do the day 2 scan in any patient and there is this follicle and estradiol levels are more than 50, then also people give the 3-4 days citro just to down regulate and then they start a stimulation.
Or if any follicle is more than 10 mm.
Yes.
For that matter.
Can you repeat, Purnima, because my network went just now? Yeah.
Ma'am, basically, from day 1 or day 2, citro is given in 2 situations. First, if the patient has got the periods earlier than the expected date in a batch IVF. So 3 or 4 days citro is given before giving the stimulation. Second situation is, suppose if we have called the patient on day 2 and she is having cyst or the estradiol level is more than 50, then 3-4 days citro is given just to suppress that follicle and then the stimulation is started.
Yeah.
Ma'am, I have a point, like one question to ask. Like,
Yeah.
has anyone practiced this? I have seen it when I was doing fellowship. I have seen this in like many patients that
I have done it in patients when I get cyst follicle more than 10 mm or if estradiol level more than 50, 3-4 days citro works very beautifully.
I have a question here again. Like my question is, does Letros of 3 days helps in such situations like 2.5?
I have never.
For 5 days. For 5 days we get.
No. For
No,
first, like suppose if they're he said.
No, let us not deviate from the point. The use of antagonist in the first 3-4 days is absolutely indicated as a protocol, but it is not a regular protocol. It is not there in the guidelines. And as Purnima said, if you have a small cyst or something, and you continue antagonist for a couple of days, that might just disappear. But I personally feel that if your patient is, listening to you, if the patient is cooperative, not too much in a hurry, you can again put her on some sort of E plus P or probably an estradiol therapy and then take her the next cycle. That is also okay. I personally don't think that, having 7 to 8 doses of antagonists is very wise, and it will increase the budget also. But I have never listened to a protocol wherein letrozole can be given in order to reduce the size of the cyst. In fact,
Okay, ma'am.
letrozole maybe, just make
No,
the
no, not
follicle.
the cyst probably, ma'am. Just the E2. I was worried. Like, sometimes the E2 is like 60, but you don't see anything gross in the scan. Or maybe it's,
So,
I'm just giving you an example, a question from my end. Does
no,
Lestros for giving 2-3 days would help?
no, it won't. It won't. No, it won't. Okay, so we will just stick to the guidelines. And again, this is, I think we are on normal responders only. Sorry, my power went. Yeah, this is the normal responder guidelines again, 2019. GnRH antagonist protocol is recommended for predicted normal responder women with regards to improved safety. This is a strong recommendation. Earlier, there used to be 10 years back, there used to be a classification of patients: PCO antagonist protocol, poor responder antagonist protocol, and normal responder go for a long protocol. But now antagonist protocol is considered to be safer and more predictable with regards to safety and efficacy even in normal responder women. And addition of letrozole to gonadotropins just to help in your protocols is not recommended. In fact, whenever you give letrozole along with gonadotropins, as we will read earlier, you might have disturbance in the synchrony of the follicles. Similarly, you feel it's a normal responder. Why should I spend 225, IU of gonadotropin daily? Let me give her something like 187.5, or let me give her around 150 for a couple of days. No. If you reduce the dose of gonadotropin in a normal responder, that's not a wise thing to do. It is better to start a fixed dose and continue the same way. So that brings us to the end of the first case, and now we have the second case for you, Akriti. This is Mrs. Polly. She is 34 years old, married only for 1.5 years. She's never used any contraceptive. She is an IT woman. They are, regularly staying together, she and her husband. But she presents to you with primary infertility. She is BMI 28, overt hyperandrogenism. Cycle length is 45 days to 3 months. Irregular lifestyle, but she wants to conceive as fast as possible. How would you, go about discussing treatment?
Ma'am,
And
for
how
this
do you plan?
patient,
Yes.
since she's obviously married for 1.5 years now, and they're staying together, so definitely she'll be eager to conceive. The first thing is that she has two problems in her system. One is
Yes.
her hyperandrogenism, the other is her obesity. So these two things we'll have to very patiently sit down with her and give her stats that what are these two things and how they will affect her the response to the follicle growth, why her periods are irregular, and this would be the mainstay that you need to first work on your health for at least 3 months. Give your time at least 3 months just for your own body, in the
So
sense it should be.
You are going to do some lifestyle counseling for her?
Yes, I will definitely, because ma'am, I do it for my all patients, and I have seen patients improving, and they actually have lasted for 1.5 years with me, and then they have conceived. But this actually helps them because I tell them is that if you change your lifestyle, that is going to stay in your life forever, and it is for your own health you're doing it, and baby will eventually come into your life.
Okay,
So it's a part of it.
Yeah, now coming back to ovarian stimulation, Akriti, she did improve her lifestyle a little bit. She, took a, sabbatical for, about 8 to 10 weeks, got lost around 5 kg weight, quit smoking, quit parties, quit drinking. But now the dilemma is she hasn't had a tubal testing done, no laparoscopy done. Would you take her straight away for IVF, or would you
No,
counsel her for IUI cycles?
ma'am, I will first, see her, like you have written, obviously hyperandrogenism. If she has reduced her weight, she has, improved physically also, and she feels more happier now. So I will first do the tubal patency test, see a look on the, AFC and the AMH also. In the meantime, like in suppose this investigations would be there. What is her AMH? What is her AFC? If it is a severe PCO, like more than 25, more than 20, or if it is having an AMH of 12, what is the LH level? All those things will be taken into consideration. Accordingly, ma'am, if I feel there is an indication to go towards lab and doing tubal patency and drilling, then I would do it at a first go. telling that, after that, the ovarian stimulation, even for an IUI, would be a better option for you with gonadotropins. And, or I will give it another example.
Okay, Akriti. So because our topic is ovarian stimulation, we will not dwell too much on lifestyle and drilling.
No.
Yeah. So now
Yes, first two options, right?
You have
Huh.
taken for IUI cycle. Please tell me the stimulation you will use. Her current
Ma'am,
weight is
step up protocol for her. Step up protocol for her. Step up protocol.
IUI.
Ma'am, in that way, I will be using Letros, and I'll be using Letros first. I'll be giving 3 cycles of Letros. Maybe first, if I see 2 point, I'll start with a dose of around, depending upon her weight, 5 or 7.5. That would be the dose I would decide for her. And I would see a first cycle with that. If it is not showing me any response, then I would switch to another mode of stimulation in the next cycle.
5 dose is, I've also used it, and actually, but 7.5 dose you can't speak, Akriti.
Okay.
It is you can't give it a routine dose of 7.5
No,
mg.
ma'am, not routine. Like
Patient.
suppose if she's lost her weight, I would start with 5. The second would be a 7.5.
Yeah, the standard dose, actually you should start with 2.5 only if she's
But I think
lost
she's
her,
obese, but I think she should be 5.
She has come down to a BMI of 25.
Still, I think 5, ma'am, for her. Age also matters.
Yeah, but
34.
never speak of 7.5 straight away. In fact,
Okay.
there was a patient who conceived in my center with multiple myomas, and my friend from Raipur stimulated her with 7.5 mg of letrozole given to her for 5 days on the phone. And she came to me with 2 follicles, and she conceived with the first IUI. She's anesthetist's wife. So when I talked to my friend in Raipur, I said, what was your protocol? She said, Monica, I have given 7.5 mg of letrozole over the phone, but I have written 5 mg because we don't write 7.5 mg. So there could be some legal problem issue, so it's better to stick to protocols. Okay, so she doesn't conceive with 3 cycles of IUI, unfortunately. So now, can you tell us, Soumya is there or she has left? Soumya has left? Okay, Mitali, how do you plan an IVF cycle for her now?
Ma'am, we can very well counsel her, as the age is already 34, and after 2 to 3 cycles of IUI, obviously the age is irreversible process. And plus, she's very eager to conceive. So it will be easy for us.
Which protocol would you use? How much dose of gonadotropin? What is your choice of gonadotropin? Tell us everything.
Ma'am, 150, 150.
Okay, you're using 150.
300.
Yeah. So there is also an algorithm for this PCO. There is a nomogram. Are you aware of a nomogram?
Yeah, ma'am, they are there.
There is a graph which you can construct out of the patient's
Patient
age,
age,
AMH,
AMH,
AFC, and then it gives you in fact, I practiced it for my patient. In one of my patients with the AMH of 10, age around 32, and lost a lot of weight. This lady with 150 international unit of recombinant FSH always formed 1 follicle. And now she's for an IVF cycle. So I used this nomogram, and this time I made a starting dose of 187.5. I was hesitant to use 200. I was hesitant to use 225. So I used the nomogram, and it worked beautifully. So anti-protocol is your protocol for choice for PCO patients. Long protocol can also be used for PCO patients, but you have to reduce the dose. And antagonist protocol is also recommended for all the high responders as a good practice point. Now, would you like to add CC or letrozole to the stimulation protocol, Akriti?
No.
Probably not recommended CC, but it's conditional. Suppose you are expert at this and you're confident about your regime, you can use CC, but definitely not letrozole. I'll again tell you about my experience. That time the guidelines were not very popular. And just to be on the safer side, I started a patient on letrozole for 5 days and then started low dose gonadotropin. That patient went in for a monofollicular ovulation in an IVF cycle, or maybe 2 follicles. So that created problem for me, though I did an IUI and she did not conceive. We had to do IVF. So sometimes this letrozole creates problem in PCO patients. So you can also use an agonist protocol for such a patient, but you have to reduce the dose in order to reduce the risk of OHSS. So what is the risk of ovarian stimulation in PCO patients? Purnima, can you tell us?
Yes, ma'am. In PCO patient, during ovarian stimulation, we can have the hyperstimulated ovaries, and the patient may land up into the OHSS, and so that is the main risk.
Yeah, and these patients, sadly can also go in for cycle cancellation sometimes. Like I told you, if your starting dose is not right, or if you overshoot, you may have to cancel the cycle either for hyperstimulated or,
Empty follicle.
yeah, not forming follicles. There is also a high chance of empty follicle syndrome in PCO. And PCO patients are the patients in whom you will retrieve beautiful oocytes in your lab. And when these oocyte, the follicular fluid goes to the embryologist, they will say that, you are not getting sufficient number of oocytes. And even the oocytes are not good quality, they are subnormal quality. And suppose this patient conceives also, she has got high risk of first trimester pregnancy loss. So in PCO patients, you basically stick to a GnRH antagonist stimulation, choose your best dose of gonadotropin, if you choose antagonist, agonist trigger, you can vitrify, freeze all and plan an FET. And if you do very few people are doing fresh transfer nowadays with PCO patients. So, what is a mild stimulation? Because this is a PCO case, I'm asking what is a mild stimulation and how does it differ from a conventional stimulation? Anybody can answer. Is there any fixed criteria to say that this gonadotropin stimulation is mild?
Mild, matlab IVF light or mini stimulation, we aim to retrieve 2 to 7 follicles.
No, mild stimulation is with respect to the dose of gonadotropin. There is the definition is definitely.
I think conventional is 150 to 225. So,
Yeah.
so
mild,
if mild is there, we are starting with a lesser dose. We are starting with a step up, like you have, mild stimulation with a small dose, like maybe cheap, they start with 75.
This is the slide, and this is the definite definition of a mild IVF.
Okay, 150.
IVF is 150 IU daily. If you exceed 150 IU daily, it will not be a mild, it will go to a conventional dose IVF. So the conventional dose is anywhere between 150 to 225. It should not exceed 225. Mild should not exceed 150. And mild IVF, you can even
Oral agents, clomiphene or letrosa also, they can
letrozole.
use.
Okay. The protocol can be agonist or antagonist, but it is the dose of gonadotropin which tells you whether it is mild or conventional dose. And all the definitions are with respect to the conventional dose. That is how you classify the hyper responder and the normal responder. So this is how the mild dose of gonadotropin is defined. I've told you. And I'll just recommend this beautiful paper is there in Human Reproduction Update of 2021, which tells you there's a meta-analysis of mild versus conventional ovarian stimulation in poor, normal, and hyper responders. And they found no difference in the pregnancy outcome, that is the live birth rate, cumulative live birth rate, ongoing pregnancy rate, and clinical pregnancy rate between the mild and the conventional stimulation protocols. Only one thing is there, the risk of cycle cancellation is more in normal responders when you use a mild protocol. That is why you told me in the first patient, let us start with something like 225. No, Akriti? Because otherwise, if you use too lower dose and the patient is a normal responder, she might just not form the correct cohort of follicles. So this is overall the mild IVF. There are many proponents now for it, but with the freeze-all strategy, people are again, going even for the harsher protocols, the conventional protocols. And this is the GnRH antagonist quick start protocol, which Purnima was talking about, wherein you give antagonists right in the beginning, start with your gonadotropin stimulation, restart the antagonist, and then you proceed like, this was Blockheel's actually, Blockheel's regime he gave long back. Okay, we can take the third case now. Akriti, I think you have to leave. Or you would like to take the third case? Okay, so the third case is a very simple case. Again, her name is Lolita. She is 31 years old and she comes to your fertility clinic with married life of 2 years, AMH of 1.0 only, AFC of 5, 2 stimulated IUI cycles which have failed and where oral ovulagens were used. She has got bilateral patent tubes, semen analysis is normal and she wants to conceive. First, you tell me which Poseidon group she belongs to. You're
Poseidon
muted.
3.
Poseidon 3, exactly. She is Poseidon 3. And this is poor ovarian response where you give conventional stimulation, forming ovarian stimulation, fewer than 4 oocytes or follicles are formed. With where you are intending to form more oocytes, you're forming less than 4 or equal to 4. So she belongs to Poseidon 3, which is actually a simpler, I find it personally out of all the 4 groups. Third group is quite simple because you are mentally prepared. The patient is young, the chances of aneuploidy are less, and the embryos more often than not implant. So the top, you can divide the Poseidon criteria by a vertical line, a horizontal line. The horizontal line will divide it into unexpected poor responders and expected poor responders. The vertical line will divide it into low aneuploidy group or younger age group. And the right side is the high aneuploidy group or the older age group, more than 35. So it is better to, have these patient-oriented strategies encompassing individualized oocyte number in your mind when you're doing your OPD. And of course, there's a percentage of each group of patient who walks into your clinic. So in a poor responder, you're going to, start stimulation for her Akriti. What is the maximum dose of gonadotropin would you use? And what is your choice of gonadotropin preparation here?
300, ma'am. Maximum is no more than 300 for me.
Yeah.
We've never crossed 300.
So Purnima and Mitali, would you use a dose more than 300?
Mom, it is not recommended. So
Not recommended. I just attended a conference, which was quite a big conference, I think Aspire or something, where people were speaking about 450 IU.
Yeah, I also attended that, ma'am, with you.
Yeah. So Akriti, remember it was 450 and
Yes.
categorically don't exceed 300 because the follicles cannot arise in, de novo. So if it is a poor responder, she's going to form the same 5 follicles or 4 follicles, whether you use, 225 or 300. Rather, you can even decrease the
Mild.
dose.
Yeah. Like
Yeah.
you said, mild stimulation 150 and those are not giving any results, different results. So why to increase it to that much also then?
So you can use even GnRH agonists. There is a school of thought which says that you can use GnRH agonists to get very beautiful and good quality coherent follicles in poor responders. But definitely your gonadotropin consumption goes up by around 30 to 40%. I have tried this. The follicles are there, but you increase the cost of the cycle by minimum 20 to 25K. Now, interestingly, there's a strong recommendation by ESHRE that you can use CC along with gonadotropins in such poor responders because the CC will give you another method of developing follicles, but addition of letrozole is again not recommended. CC alone or in combination with gonadotropins can be used for predicted poor responders. This we have to keep in mind, and definitely a higher dose above 150 is, you can use anything 150 to or above 150, but above 300, there is no justification to use a dose more than that in poor responders. Now, who can tell me what is natural cycle and what is modified natural cycle, Purnima?
Mom, in natural cycle, we just let the follicle grow and we are not supplementing anything. But in modified natural cycle, we are supplementing oral ovulation, I think.
No. In modified natural cycle, we are giving antagonist and we are giving the trigger.
Okay.
Two
Yeah,
things. We are giving either the antagonist
Or
and
the trigger, correct.
or we are giving either antagonist or trigger or either of the two. But you're not using any sort of ovulation inducing agent. Okay.
Agent.
So when it is a poor responder, the use of modified natural cycle is not recommended. You should always go for a conventional stimulation protocol. Okay. Don't use any fancy things because you want to harvest the maximum oocytes in this woman. So this is the question which I wanted to ask you because this is something we, forget in because we study such complicated things that we sometimes forget the basics. So this is Elonva. If you go to ESHRE, you'll see that it's now been available, but it's not available in Indian market. The beauty of this drug is that it will keep the FSH level above the threshold. Akriti told us about threshold, or Mitali did. It will cause multifollicular growth to happen for 7 long days. But the dose you have to use is adequate because if you use a lesser dose, the live birth rate will reduce. Now, the disadvantage of this Elonva is the OHSS level also goes up because Whether you like it or not, the FSH will start getting released. Okay, so any experience with this protocol, Mitali? See, you can have a look. What is this? This is being used in a poor responder.
Where is my screen?
Mitali is there? Only Akriti and Purnima are there?
Ma'am, I have not seen this.
Okay, so this is, Purnima, any experience with this protocol?
No, ma'am, not with this protocol.
So this is a typical protocol of, I think before 2018, this was used for poor responders. The IVF specialists of my times, or even senior to me, used to use the flare protocol. In order to harvest the maximum number of oocytes, they're using microdose flare in the day 2, 3, 4, 5. Then they are giving letrozole in a dose of 1 tablet, 2 tablet, 3 tablet, and 4 tablet, and then starting FSH. So this is the advantage that letrozole can give you. Reduce the dose of gonadotropin in poor responder and probably give you a good, and people are still using it. Then there was something called Cato's clinic in Japan. Dr. Rishikesh Pai went there and he was, all praises about this clinic. This is a clinic which gave tremendous, this clinic is doing 10,000 cycles per year. And they have got very, very less amount of gonadotropin. You see what they do. They start CC tablet 50 mg right from day 3 to day 12, 10 days. So because of CC, there is no need of adding antagonist because CC itself will prevent the premature LH surge. And they give alternate day 150 IU of FSH only. They will give on day 8, day 8, 10, and day 12. Then they will give an agonist trigger when the E2 is more than 300. Do a pickup, do a day 2 transfer with extra luteal phase support. So this is called Cato's protocol, and this is very old, but I just told you because it is still there described in the poor responder section. So again, we are going to the guidelines. And tell me about something about, we know the LH suppression regimes. We are all, I think, using antagonist protocol. If any of you is using agonist protocol, you can share. But in general, antagonist protocol has got a strong recommendation to be used over agonist protocol because it gives totally comparable efficacy and higher safety in the general. Now, who has used PPOS protocol and what is it? What is progesterone primed ovarian stimulation? Where is it being used? Even if you have not used it, what do you know about it? Purnima, Akriti?
Ma'am, I've heard it in conferences and many of them talk that it is really good. I have not yet got the courage to start in any of the cycles, but yes, they say that in donor cycles, they're using it for reducing the costs. So donor egg cycles, stimulation cycles, they're using it quite commonly.
Yeah, I recently had a patient who came to me with, non-Hodgkin's lymphoma, and she was taking chemotherapy. After the first cycle of chemotherapy, she came to me for egg freezing, and I was very much in a mood of starting PPOS for her because that has got very good results. It is basically for fertility preservation for, cancer patients, oocyte donors, freeze-all cycles, because here progesterone is very, very efficacious to prevent the premature LH surge. The only thing is here you can not do any sort of embryo transfer. So
fertility preservation.
You have to do either oocyte vitrification
Preservation. Embryo freezing.
Yeah, we will just talk about it. Now, just a word about gonadotropins. Do you feel recombinant FSH spending so much money is worth it? Do you think there is an edge over HMG? Or are we just buying, these costly recombinant FSH and people are saying it is equal to HMG? What do you think?
I think it is better than the HMG.
Sometimes you feel that a happiness factor with follicles when you give recombinant FSH, don't we? Yeah, because sometimes the HMG which you are buying, that even that HMG which is, 150 IU, you sometimes feel that what response it is giving. And the same thing if you give 150 IU of recombinant FSH. So I think it is something to do with the Indian batch to batch variability.
Probably.
Cannot trust the gonadotropin. The same gonadotropin of 150 IU will be, so one company is giving for 1200, the other company is giving for 2500. Okay. So there is something called highly purified FSH, recombinant FSH, HMG, but the guidelines say it is all the same. It totally depends upon your budget and the patient's budget, what you want to use. We don't use recombinant LH, so we'll not be talking about it, but you can go through the guidelines. Letrozole is not recommended in place of gonadotropin responder. And you can use either the long-acting FSH or the daily FSH, and we don't have an option. Now, your patient is not responding to 225 IU gonadotropin, this poor responder, Akriti, and you are day 6 of stimulation. Would you adjust the dose?
She's which day, ma'am?
She's
Day 6.
Day 6 of stimulation. You have started 225 IU AFC 4.
And it has not responded. Like none of the follicles has come beyond 10.
Yeah. There is
we'll increase the dose.
Yeah,
And
you will
see.
increase the dose, of course, but what the guidelines say, it is conditional recommend that when you do in the mid stimulation phase, a fine adjustment, increase or decrease of the gonadotropin dose, it is not recommended because any increase or decrease which you make will take minimum 3 days to take the effect in the body. Okay, so if you do, the recommendation is don't adjust, choose the right dose in the beginning, but of course for poor
Beginning.
responders, I feel sometimes I do adjust. Now, which are your favorite adjuvants? Just we'll go fatafat through it. Which are your favorite adjuvants? Adjuvants are again, all of them are no, but some of them we are using. So,
DHA.
yeah. What about aspirin? Let us discuss one by one.
No.
Anybody using Ecosprin or aspirin 75 mg before
No,
IV?
ma'am. For stimulation.
No, not for post, just general. Any IVF cycle.
No, ma'am. No.
Okay, so there's a strong recommendation that use of aspirin before and or during IVF cycle, ovarian stimulation is not recommended. Second, sildenafil.
No.
DHEA?
Yes. Yeah.
Yes.
And we're using. We are
Yeah.
using.
What is one message about DHEA you'd like to give, Purnima?
That
You have to use it 10 to 12 weeks before you start your stimulation. Otherwise, you're not going to, influence that much.
8 to 10 weeks. Yeah. 8 to 10 weeks.
Actually, it is 12 weeks, but even if the patient takes it for 8 to 10 weeks, it's okay. It has got a greater recommendation as compared to the testosterone gel.
Gel.
So
Ma'am,
much.
that transport trial was there. Has not the results come out of it? Which was
The
there
result-
that.
The results have come out in last Ashray.
Ma'am, उसमें क्या हुआ था? What was the results?
Totally useless.
अच्छा.
Not this was a full jam-packed hall in Ashray. I did not go last Ashray, but I read the T-transport trial that day only.
No, but
And-
I had read in my fellowship. So I had remembered that it will come. But I was searching. I did not get the results.
No. T-transport trial, you read Nicholas Polizos. It
अच्छा,
is there.
polizos. Yeah, polizos.
Polizos has-
He only does work.
Totally it doesn't work. So after that, testosterone gel has fallen down like anything. But people are using DHEA and DHEA is being used. And sometimes DHEA is also being combined with melatonin. No, Purnima?
Yes, ma'am.
So testosterone
Combination.
before stimulation is probably not recommended. T-transport trial is negative.
Okay.
Adjuvant growth hormone, anybody has used? It's a conditional. It is yes and no both. You can use adjuvant growth hormone. It's not very costly. And I have a good mind to start growth hormone in few of my poor responder patients because it is very popular in many metro cities.
Ma'am, yes.
It is not very expensive. It is
Yeah.
not, patient can afford it very nicely.
Afford, yeah.
Yeah. So again, metformin is a no. Of metformin we are using in PC.
Antagonal.
No need to use it in ovarian stimulation. Now there is something called random start luteal phase protocol. Anybody has used dual stimulation, double stimulation, luteal phase stimulation? Again, this is for social egg freezing and for cancer patients. We will not discuss it in detail. As in when we start, doing it, we will gain our experience. And I think PPOS we have talked about. These are beautiful slides on PPOS by one of the greatest proponents. I was listening to some lectures, so I took a slide. You would like to listen to it?
Yes, ma'am.
is, see, this is the upper graph is the conventional ovarian stimulation. With these are the gonadotropin doses
Gonadotropin.
from day 2. And these are the anti-dose. Okay. PPOS may you start gonadotropin the same way, and on the day of gonadotropin, you start 1 tablet of medroxyprogesterone acetate 10 milligram per day. That is, it is as simple as that. There will be absolutely no LH surge. You do OPU, you give the, trigger, and after doing the pickup, you have to vitrify the oocyte or vitrify the embryo, whereas in the conventional protocol, you can plan a transfer also. So this is how simple it is. And, there is also a dual stimulation, wherein you can do one part, follicular phase, you can do PPOS, and the next phase you can do conventional sort of stimulation with antag. People have studied that also, but I have not used it. PPOS also I tried to use, but then I went to antag because I did not trust myself. So progesterone primed ovarian stimulation blocks the LH surge through progesterone instead of traditional downregulation or GnRH antagonists. This serves as a very cheap alternative to conventional treatment with analogs and antagonists. And the beauty is you can also use MPA, you can also use dydrogesterone. So this is a huge trial which has been done in China, published in 22, wherein they have seen dydrogesterone to be safe and efficacious treatment modality for freeze-all cycles, and all these blastocysts were subjected to PGTA. They found no difference in the euploidy rates of dydrogesterone group versus the antagonist group. So basically, the progesterone will not have any effect on the aneuploidy also. That is why there is a big future. The SWOT analysis has also given us a lot of positive points for PPOS. So our guidelines also say PPOS is there, but it can be used only in non-transfer cycles. So I think we can skip this. Fertility is over. Conclusions are over. Akriti has to go for dinner.
Ma'am, I
Yes.
have invited guests on dinner today.
So you can leave. We are just concluding. One very important thing is endometrium we measure every time during ovarian stimulation. We measure the follicles and then we measure the endometrium. Should we measure or not measure? Purnima.
We should measure, ma'am, because the thickness of endometrium can also give us idea about the follicular growth, and as well as the thickness. The endometrium, like before embryo transfer, we would know about the endometrial thickness and everything.
Yeah, so the guidelines say that performing a single measurement of endometrium during ultrasound assessment can be done just on the day of trigger or the day of pickup. And that is only to counsel the patients that what is your chance of a pregnancy. You don't need to measure it every day. You can just measure it just on the day of trigger. And of course, for triggering, you can either go for the estradiol or you can go for the follicle size. Generally, it is the follicle size. And there is something also called the oocyte follicle ratio. Cycle cancellation. A poor response to ovarian stimulation is not a reason to cancel the cycle anymore, even if you're getting 2 follicles. Okay? Earlier, there used to be a recommendation 4 follicles cancel the cycle, but now it's not there. Triggering, you have to use, if you use HCG, try to go for a 5K dose. Agonist, you know when to use. Dual trigger, there are specific guidelines. You can use for agonist trigger triptorelin, you can use buserelin, you can use leuprolide. It depends upon your budget. When to use a dual trigger is again a conditional recommendation, not for normal responders. There is some indication for dual trigger in PCO, some in poor responders. I have presented in ESHRE both these studies. And of course, a GnRH agonist trigger for final oocyte maturation with a freeze-all strategy is much better than coasting, which we used to do earlier. Freeze-all is again, recommended to fully eliminate the risk of late onset OHSS. And that is why before starting ovarian stimulation, you should always assess the risk of OHSS. So which are the patients who are at high risk for developing OHSS? Purnima?
Ma'am, the PCO patients and the patient who responded had hyperstimulated ovaries in the previous cycle.
Yeah, they have got the ovarian reserve test is abnormal, high response indicated by ultrasound, high E2 levels. So freeze-all strategy, you can counsel the patients. Is there any benefit of using preventive measures after stimulation like cabergoline or albumin? This is all.
Cabergoline after pickup has a role in preventing.
But not, it doesn't have any role when you're using agonist trigger. Okay. If you're using agonist as a trigger, you're virtually eliminating the risk of OHSS, especially if you're doing a freeze-all cycle. Okay. So you can avoid the using cabergoline or albumin. So thank you so much. You have to keep learning right from womb to tomb. The brain has capacity for learning that is virtually limitless. So every one of us is a potential genius. Okay. So that brings you to the end of the panel. Thank you so much. And we will
Thank
stop.
you, ma'am. It was very nice.
Thank you, ma'am. It was very wonderful. And I first time have understood PPOS today. I will definitely use it. It is very simple.
It's very simple, very, very simple, very simple.
One question to ask you.
Yeah.
Do you use ANTAG in modified natural cycle?
Modified natural cycle means any the natural cycle is there, but you have one good follicle, and you feel that may undergo premature luteinization. And that follicle is very important to you. You can give 2-3 doses of ANTAG just to pull it through to become 17-18 mm. That is it.
But when do you feel like it will go on to premature this luteinization?
When it is growing very fast, when it is causing a very thick, lush endometrium to grow, when the cervical mucus starts appearing in the cervical canal, these are the 3 features of imminent ovulation.
In those
cases, there is a discrepancy. Suppose the follicle is around 14 mm, 12 mm, and the endometrial thickness is only 6 mm, and you want to do a natural cycle and you want to do an embryo transfer. So you can give ANTAG for 2 days, the follicle will not rupture. And the endometrium can be made to grow in that time with the sildenafil or something.
Yeah, sometimes endometrium grow at a later stage. When follicle become 20 mm, the endometrium grows.
Yeah.
One more question. Like in PPOS protocol, which trigger you want to use? Which will be the best trigger?
See, PPOS protocol is all freeze-all. So it is better to use an agonist trigger and freeze the oocyte or freeze the embryo, whatever. Recently, we did oocyte vitrification in 2 patients. One was the NHL patient and one was social egg freezing. Oocyte vitrification is really nice, very gratifying. Suppose you learn that technique and do it, it is not that tough. We keep separate liquid nitrogen canisters for that. Proper labeling is required. And it's a very gratifying procedure. So I think more and more patients will go for vitrification. And but all said and done, fresh embryo transfer also has got good results. The fresh embryo transfer will need proper timing. So for PPOS protocols, you have to use an agonist trigger and freeze.
You have used PPOS protocol?
I told you I was going to put a patient on PPOS, but she was from a very VIP family. So I thought I better not take any risk.
I think I'll use PPOS, and I don't have guts to start, but I think I should start. At least in donors, it will save money.
Fessy sir must have used. Fessy sir must be
No, I am not using PPOS because I am also, as told, not afraid till more people are used to it, because I think I know a few people who are for donors, they are using progesterone pride. I am taking their data and experience so that in future, because something which you are used to it and which you are comfortable, it's unless you are sure, just like that, it is very difficult to change that. So,
but Fessy sir was the first person who introduced me to growth hormone.
That I've been using many years.
Yeah, sir. 7-8 years back, we were traveling together to Hyderabad, and sir gave me the complete protocol, growth hormone, off-label use tha, and he gave me the confidence.
2 things is there. One, the brand which were available till that time per unit was 1,000 rupees, and all the foreign studies were with 8 units. And the brand which available in India is hardly 400 rupees for 1 unit, and we use 2 units and reasonably good result we are getting. That's why, and the cost, it can be used very cost effectively.
In which dose you are using growth hormone?
2 units right from the stimulation. Along with that, those patients who need I mean, high dose, I mean, 300 or 450 use, I mean, poor responders. It doesn't increases the antral follicle, which we are not seeing, but whatever antral follicle we see, that will come up and we'll get reasonably, reasonably good usage with that. Poor responders, not for other patients.
So which brand are you using now? So which brand are you using now?
Two brands are which are cheaply available. One is Utropin by the Cipla LG, and another is by the Reliance has got one growth hormone. Two brands are there.
Okay.
Both are coming in. Per unit costs are 450 rupees.
Yeah, they're quite cost
How
effective.
many days?
Right from the stimulation till the day of HCG.
Till the day of HCG.
Okay.
Yeah, because I listened to Fessy sir and then only, I started using. And some patients came to me from Fortis, Chandigarh. Some patients were getting IVF done at Rishikesh Pai sir's center in Fortis, Chandigarh. They came to me only for the stimulation and growth hormone. Then they returned for the retrieval. So, like, I was a sort of third party. So that time I gave a lot of growth hormone to these patients. Yeah.
Got good results?
Sorry?
You got good results with growth hormone?
No, the patient didn't conceive. The patients were really poor responders. AMH, something like 0. They did, I don't know, 0.1 AMH, 0.2 AMH.
Dr. Anu, it is not like that. If you don't see antral follicle, it won't come up like that. If you see 4 antral follicle, that will, most of them will come up. That is how it is. I think I've been using for more than now 13, 14 years. 2013, Mumbai ACOG, I presented it and got this thing. Prize for the this thing. What was that? Not the free paper, one prize I got for that.
Thank you so much, sir. And thank you, Anu, for the wonderful opportunity. Though I would just give you one suggestion, Anu. There are lots of dropout. Purnima has done webinars with me. So panelists really drop like, apples from a tree. So it is better to keep minimum 10 panelists. When you keep 10 panelists, then 5 will stay.
I'm sure Dr. Purnima will.
I kept 8 panelists and all of them came. So finally we decided we'll keep lesser panelists so that they can get the chance to speak.
Actually, panel discussion is right at the end, no? So panel discussion, everybody leaves some commitment or the other. It's okay. But then the, discussion is not much.
More.
We used to keep minimum 10 panelists, ma'am. 8 to 10 panelists.
So, ma'am, I'm sure your teaching actually reminded me of my teachers at KM Hospital in Mumbai, with what love and care they used to teach and help us understand each and every simple concepts. And I'm sure that Dr. Purnima, who has sailed through the entire panel discussion, would be the next doyen after you, ma'am, in the IVF field. I think he'll reach bigger.
Ma'am is my teacher and ma'am is like my professional mother, I always say, in the city of Bhopal. And it's an honor to work under ma'am guidance, and ma'am is a wonderful, wonderful teacher.
Sure, yeah.
Thank you so much, Purnima.
And thanks, ma'am, to you for taking it so nicely and so clearly and explaining in so simple words to everyone of the audience who would have got mesmerized with the kind of opera which you conducted with your panelists, ma'am. And obviously, Dr. Anu Agarwal and Dr. Fessy Lewis, who have been a big sutradhar for this fertility catalyst. Pallavi, you want to say a few words?
Yes, hello, good evening to all the doctors present out here. Listening to all you speak, especially Dr. Monica Singh and all the speakers before you, I think it was music to my ears. You have been helping patients with such astute and minute details. I'm sure India has a bright and a great future with, gurus like you who are handling the patients. So thank you so much, ma'am. And Dr. Fessy, Dr. Anu Agarwal, thank you so much for being a part of this ISAR webinar and helping UNS host this for you. And I'm sure the content that was shared today has been an absolute food for thought for all the doctors who attended it and also for the participants. So thank you so much from the House of UNS. My name is Pallavi More and I head the marketing team here. And I think this is a great opportunity for us to connect with all the ISAR members and all the budding IVF specialists and the ones who are also called as the mother and the father of IVF in India. So thank you so much for all this. I'll pass the baton now to Vikas to thank a heartfelt thank you from all of us. Vikas, over to you. Thank you.
So I would like to conclude the meeting by a thanks note. And just to start the thanks note, I would like to highlight the logins of the event. Though it is 9:45 or 9:40, the event has ended, but the login has increased. Like at the, I can see at 9:15 it was around 300, but at the 9:30 if I see it was 312. Though it's a 12, but it has not dropped down, it has increased. So you can so I can understand what is the discussion and how important and keen discussions were happening, so that the participants have not dropped out even after the event had got significant delayed from 9 to 9:30 or 9:45. So to start the thanks note, I would like to first thank Dr. Amit Patki sir and Dr. Asha Bakshi ma'am, and further Dr. Anu Agarwal ma'am and Dr. Faisal Louis sir. They have been the real catalyst in organizing such a seamless event and bringing all the IVF experts from India. It's around 70 to 18 doctors.
Some network issue, I think.
And how seamless we have organizing this webinar. I would also like to thank our chief guest, Dr. Rishi Pai sir, and guest of honor, Dr. Charudar Joshi sir. Their presence has greatly enlightened this event today, and all the chairpersons, all the speakers, Dr. Rajul Tyagi ma'am, Dr. M.S. Srinivasan, Dr. Randhir Singh, Dr. Neela Mori, Dr. Priyankur Roy, and Nishad Chimute, and to our esteemed speaker, Dr. Kanti Bansal and Dr. Ashwini Kale. I would also like to thank our moderator, Dr. Monica Singh, who has been instrumental in driving this panel discussion, and she has taken the lead 2 days back as Dr. Seema Pandey was not well, and accepting the invite, preparing the slides, and doing such a long and wonderful panel discussion and engaging such a 300 delegate audience is not so she has done a tremendous job. And lastly, I would also like to thank all the panelists, Dr. Akriti Gupta, Dr. Mitali Gupta, Dr. Purnima Tiwari ma'am, Dr. Soumya Mathur, and Dr. Anuradha Pancholi for their valuable contribution to this panel discussion. For Soumya Mathur, Dr. Soumya Mathur has messaged me that her sister has been delivering a child, so she went back. So I just informing you. So that was a one panel discussion drop off. So we can over to you, Anu ma'am. You can conclude the session and we can definitely.
Thank you. Thanks a lot, everyone. Thank you.
Thank you. Thank you.
Thank
Good
you.
night. Good night. Bye-bye.
Thank you all. Good night. Good night.
Good night.
Good night, sir. Good night, Anu. Good night, Pallavi, Manish, Vikas, and
Thank
you, ma'am.
Bye.
Thank you, ma'am. Good night.
Bye.
Thanks,
Good night.
everyone. Good
Reminder
night.
to the audience that this meeting happens every first Tuesday of every month. So this is a recurrent. So see you next month on the first Tuesday of the month. Yeah.
Thank you, ma'am.
Thank you, madam.
Thanks.
Madam, you were there throughout the marathon event, madam. Amazing. You're maintaining your energy level. That's amazing, madam.
Chalo. Okay.
Any words from your end?
Hello.
Anu Agarwal, madam, I was saying any words from your end? It was a long session. I wonder how you keep
It
your.
was honest. Now I'm going to OT. 2 scissors are waiting for me.
Okay, ma'am, please.
Thanks for your technical support.
Sure, ma'am. Thanks a lot.
Thank you.
So good night.
Good night.
Good night.
Good night. Thank you.